I think the anomalies of arch-sightedness, mainly what you're talking about is the right aortic arch, and it is an easier diagnosis. So this is going to be a short and sweet talk. After that, exhaustive information on the more complex abnormalities. So the normal aortic arch actually is the result of recreation of the primordial paired aortic arches. We all know that it is a very complex embryology. So normal regression results into the left aortic arch, left-sided arterial duct, and there is a normal branching, which is right innominate artery giving rise to right subclavian and right carotid, and then left common carotid and the left subclavian artery. So if you are considering the anomalies of sidedness, it is the right aortic arch and its branching anomalies and the vascular rings. So we, in this today's talk, we will see in short about the embryology. We know embryology is boring, but it's interesting to know why things happen the way they do. Then the ultrasound diagnosis, which is the most easy part, because we have been doing 3-vessel trachea view since the last few years, always in our cardiac screening. But what is important is what next and what to advise, because it is a simple or a straightforward abnormality. If it is not associated with any other cardiac problems, do we just leave it like that? And how do we assure the parents? So this is the hypothetical double aortic arch theory, which was suggested by Edwards, and this is the ascending aorta, and this is the double arch. And there will be two arteries coming from both the sides, the common carotid and subclavian, and this side common carotid and subclavian. And then there is a regression of this particular segment, and then this becomes a common trunk, and then the carotid and subclavian, and this is the left-sided carotid and the subclavian. So that is how a normal left-sided arch which is going to develop. And since we have this kind of image that there is the arch like this, you get this typical V, and this V is to the left of the trachea. So this is our typical 3-vessel view. So this is just a schematic representation of these different segments in the hypothetical model of the double aortic arch. And then what can happen is, normally we saw that this particular segment is going to disappear and we get the normal left-sided aortic arch. But there can be a lot of other things which can happen. There can be regression of this side, and then what we will get is our typical right-sided aortic arch. But there may be the regression of one particular segment here. There may be a regression of this segment here. So there are going to be different permutation combinations, and then they say there are more than 20 kind of different variations which are possible. But we will what we see antenatally is basically the right aortic arch and the double aortic arch and the ARSA. So right aortic arch is characterized by the abnormal laterality of the aorta and brachiocephalic vessels. It courses to the right of the trachea. It may have the mirror image branching pattern, but the aberrant origin of the left subclavian, that is the ALSA, what we call, is the most commonest form. And in fact, it is a very common kind of abnormality. The incidence is almost 0.1%. So I think in a busy obstetric unit, you can say if you don't see any ARSA in say 2-3 months time, you should be worried, are you missing out on something? So as we said, the right aortic arch can have 3 types. RAA with ALSA, which is the most common type. What is happening here is only this small segment is regressing, and this entire retroesophageal diverticulum, what they say, the glomerule, this gives rise to this ALSA. So this is the commonest form, what we see, which forms a U-ring. Then the RAA with mirror image branching. So what is happening here, as you can see, that this particular segment has regressed, and this is exactly the mirror image of what was actually happening on the left side. So the first branch to come out is going to be the left brachiocephalic, then the right subclavian and the common carotid. So this is the next common type of abnormality, and a very rare abnormality which we will not really see prenatally will be when this entire segment disappears. Now, when the baby is born, you will say that this particular left subclavian artery gets isolated. It is not getting supply from anywhere. Or if there are two segments which are, getting regressed, then what is happening is this left brachiocephalic artery is going to get isolated. Now, where is the blood supply going to come from? It has really got sort of cut off from the aortic arch, and then it starts taking the blood supply from the collateral arteries. There is a steal phenomenon and things like that. But for prenatal diagnosis, the commoner ones are RAA with ALSA and RAA with mirror image branching. So the vascular rings, again, there can be pulmonary vascular rings, but which are not so commonly seen. So typically the right aortic arch and the double aortic arch. So the vascular rings are a heterogeneous group of anomalies encircling the trachea and the esophagus. And the classical vascular ring, which commonly is seen, is formed by the right aortic arch, left-sided arterial duct, and an ALSA, which arises from the glomerulus diverticulum. And it may be asymptomatic. Symptoms of compression sometimes may develop later in life, like dysphagia, stridor, wheeze, recurrent URTI. Prenatal diagnosis is important because it is associated with certain cardiac and extracardiac abnormalities, and it has the association with chromosomal defects, in particular 22q deletion, not very commonly seen, but it is known. So this is a typical U-shaped ring. This is the SVC, aorta, and pulmonary artery. Normally, we know nothing moves behind the trachea, and when you start seeing something like this, you know this is a typical U-shaped ring where the arterial duct is also on the left side, and this is the typical form of the U-shaped ring. What is important is to look for the left subclavian origin. As you can see here, you can see it subtly. Your PRF settings, as Dr. Mark says, your alignment, your physics should be good, your technique should be good to get these kind of smaller vessels. So what you can see here is the ALSA. This is the commonest form of the vascular ring or the branching of the RAA. As compared to that, if you come to this abnormality, this is the normal branching, what we saw. This is the normal V to the left of the trachea. If you can see here, this is the V which is forming to the right of trachea. Where is the trachea? Trachea is somewhere here. And this is forming a V to the right of the trachea. This fetus also had agenesis of ductus venosus, that single umbilical artery. It had anal atresia. In fact, there was a urorectal septal malformation deformity along with. So this is typically the right-sided V. This is a mirror image branching. This is trachea here. This is the right side and this is the left side. So SVC, aorta, and pulmonary. And it forms that V which is to the right of the trachea. And these are the ones which are commonly associated with other problems, and it is not just a common variant. So on ultrasound, what we see is a U side RAA with left arterial duct. It is a loose vascular ring. In almost all cases, there is an ALSA arising from the junction of ductus arteriosus with descending aorta, and the right V side, which is RAA with mirror image branching, right arterial duct, no vascular ring. And again, the color Doppler is always helpful, but even your grayscale imaging tells you immediately, because we are so used to seeing that 3-vessel trachea view. So this is just a graphic representation. This is the U ring which will be formed because this is the ALSA. The first artery to come out will be the left common carotid, the right common carotid, the right subclavian, and then the left subclavian, which is aberrant. And this is the mirror image branching, where the first one will be the left innominator brachiocephalic, which will divide into two, then the common carotid and the subclavian arteries. So this will form the V kind of configuration, and this will form a U kind of a configuration, and this is the right aortic arch. So mirror image branching will be V-shaped, and the U-shaped branching will be with the ALSA, or you can say left innominate artery. This is less commonly seen, and this is more commonly seen. There is a high likelihood of cardiac anomalies, most often conotruncal, and there is a low likelihood of cardiac anomalies, and it may be associated with conotruncal, but not very commonly seen. Again, the one with the mirror image branching, there will be high likelihood of chromosomal abnormalities, and in our arterial vascular rings, U-shaped rings, it will be a low likelihood of chromosomal abnormalities. So the right aortic arch is best detected in a three-vessel view, but you should always remember to differentiate it from the double aortic arch, because that is going to be a more severe kind of an abnormality. It will be symptomatic more often. So you have to do a slight oblique view, just cranial to the three-vessel trachea view. And then this is where, see, this is a little oblique view. You can see, so many ribs. Normally, we only see a single longitudinal rib here, and then here you can see that this aorta is branching, and this is the trachea here. And you can see, of course, with color Doppler, that this is the branching pattern of the double aortic arch. You should not mistake the subclavian, which also goes slightly in that cranial section, but then it will have a different direction color pickup as compared to the double aortic arch. So that will definitely differentiate it from each other. So this is typically the double aortic arch, which is forming a tight loop or a tight ring around the trachea and the esophagus. So this is how you will see it. And as I said, that there will be the brachiocephalic vein, but it will have the blood flow going from left to the right, because it is ultimately going to join the SVC. And that's why you can always differentiate it when you put on the color. So aorta bifurcates into right and left, and this typically has that the Greek lambda sign, or the reverse N sign, what they call. It is behind the trachea. Both the arches will join to form the descending aorta. Esophagus and trachea gets entrapped between these two arches, and usually two vessels arise from each arch. Sometimes the left arch can be narrower than the right arch, maybe hypoplastic. Again, it will be easier to look at that when you are doing a sagittal section. In fact, for the right-sided aortic arch, as Dr. Mark showed us, is that the arch view also you can make out. You can see the trachea in the sagittal section, and the sidedness of the arch can be made out even on the sagittal view. The narrowed arch can be made out on the sagittal view sometimes better than the three-vessel view. So this is typically the graphic representation of these abnormal patterns of sidedness. This is the V-shaped of the ring, V forming to the right. This is a typical U ring of the right aortic arch. And you can just see that there is a U shape of a ring, but you should look for this branching and then rule out the double aortic arch. Then again, I don't have that much expertise like Balu has. These are taken from the internet, but the 3D immensely helps. The newer techniques of the color Doppler, like HD flow, the B flow, again tells you about these branching patterns very well. And this is a 3D reconstruction. I've taken it from the internet. So what helps in diagnosing these problems of branching or the sidedness is not just these three views, the three vessel view, then the branching of the pulmonary, what you see, and then this three vessel trachea view, but you should try and come a little cranial, come more cephalic, where you see only the aortic arch, because you know that the aortic arch is the highest one. The ductal arch is not seen in this view, and the branching pattern of the left subclavian and the right subclavian. So when you get used to seeing this in all your fetal echo patients, you tend to pick up these problems of sidedness and the arch branching more. So what should be done next? Because these are easy to diagnose. They're not, say, associated with any other problem. Of course, a detailed anomaly scan and fetal echo is a must. But when you start seeing a right aortic arch, you should rule out heterotaxy and additional signs of isomerism. Because we said we start doing the fetal echo, first thing you take is the upper abdomen. And there, if you see the arch is on the right side, you are more commonly thinking in terms of heterotaxy and isomerism. In right aortic arch, most of the times when the descending aorta starts, it is on the left side of the spine or just anterior, but it is not really on the right side of the spine. So if you see it in that section, in the upper abdomen, in fact, you're thinking more in terms of heterotaxy. Then if you see a right V sign, which is a rare phenomenon, which is commonly seen with associated anomalies. So you should look for cardiac anomalies and you should look for the other signs of chromosomal problems. If you see the U sign, of course, you rule out cardiac abnormalities, but you also look at the other extra cardiac abnormalities, the face, the thymus, the abdominal vessels, etc. If isolated, then the prognosis is excellent. Look for the origin of the subclavian always. When you have the doubt whether it is a double aortic arch, you should always check in the higher oblique planes for bifurcation of the aorta and check for the compressed tracheal lumen. In fact, you can check in that sagittal section, the trachea will be seen, and if you can see that it is getting compressed by that sagittal view or using a 3D reconstruction, it really tells you whether there is a compression of the tracheal lumen even antenatally, and it is possible. Then again, if it is an isolated finding, do we advise invasive testing? Then there was a meta-analysis paper which was published in 2016, and they have kind of seen if the chromosomal abnormalities are commonly seen in these patients. Right arch with normal intracardiac anatomy. Then they have found that the incidence of the chromosomal problems is still there. Symptoms of vascular ring are 25%, associated extracardiac diagnosed prenatally is 14%. And if you see that if you do a good anomaly scan and there are no extracardiac abnormalities and no intracardiac abnormalities, the incidence still drops down further. But again, these meta-analysis studies, especially of the arch-sidedness, should be taken with a pinch of salt. Now, this was published in 2016. They have taken into consideration the studies which are, say, 15 years before, all the studies which are done in the last 15 years. We all know that we started incorporating the 3-vessel trachea view into our, cardiac screening, probably since the last 7-8 years. So we need more data to come in, to see there will be less cases picked up, in fact, in those studies at that time. And now we pick up more and more cases. So we will have a better understanding now. So this was relatively latest, published in 2019. Here they have called it as isolated right aortic arch when there were no intracardiac abnormalities. They have not taken into consideration the extracardiac ones. So then they said that 7.5% of the cases, the right aortic arch was associated with chromosomal abnormalities. And when it was not associated with extracardiac abnormalities, the incidence was very low of the chromosomal abnormalities. So whenever the diagnosis of right-sided arch is made prenatally, a detailed examination should be conducted and the option of invasive testing for CMA should be discussed. We don't offer it to all these patients. So a postnatal follow-up is a must. Patients should be counseled about symptoms of vascular ring, so the parents are watchful. Postnatally, all cases of right aortic arch should have cardiac assessment to rule out additional minor intracardiac abnormalities, confirm the arch anatomy, especially the origin of left subclavian artery if it was not clear antenatally, and of course refute the presence of double aortic arch if you may have missed it in your antenatal scan. Even though you are very careful, sometimes it is possible to miss out on these things. So it is always better to have a postnatal echo, a neonatal echo. In the end, we will see the most common abnormality, what we say ARSA. It is the abnormal origin, the anomalous origin of the right subclavian artery. Incidence is 1% of general population, so it is pretty common. Normal left-sided arch has 3 branches. ARSA arising as a 4th vessel is the aberrant left subclavian artery. And as you can see here, this is where it is seen, and then it courses behind the trachea and then goes to the right side. So that is where the abnormality is. And branches of the aorta now will be the right common carotid, the left common carotid, the left subclavian, and then the arsa. So it is seen as the fourth branch, retroesophageal right subclavian artery or a Luzonian artery. So what is happening here? Now, where is the regression? It is at this site. So what happens is this segment forms together, and when there is a turning of the arch, you start seeing it as the aberrant right subclavian artery. So this is how it will normally, this is what happens, this even regresses, and whenever there is regression of only this segment, after it turns, what is happening is this is the, now this particular segment is getting the supply not from the arch but from this descending aorta, and that's why you see it as the fourth artery which is going behind like this. So this is typically seen in a three vessel trachea view. This is the trachea here, and you can see something going behind the trachea, and it is the aberrant right subclavian artery. You should not confuse it with the azygous joining the SVC. It has a vertical orientation, but this has that horizontal orientation, and you should always confirm it with the pulse Doppler so that you don't really mistake it for something else, for a vein. So you should always put on the spectrum, and this is where you see. So as I said, this is the azygous which joins there. This is the one. So you should not mistake it for something coming behind the aorta. And this is the normal branching pattern as you come little higher. So this is the view which you should always incorporate in your fetal echo technique. The other way of looking at it, of course, a three vessel trachea view, but the other ways of looking at it is, this is the coronal section. This is the descending aorta, and where you see the artery arising from there is going to be the extra artery which is coming from there is going to be the aberrant right subclavian. Even in the sagittal section, you can see something coming beyond the left subclavian, and you see it turning like this and going towards the right side, and that is the aberrant right subclavian artery. So it is best seen in the three vessel trachea view. It courses behind the trachea to the right upper arm. It is not a grayscale diagnosis, but only on color Doppler. By lowering your BRF, only then you will see it. With the directional power angio, you tend to see it little better. You have to lower the color velocities, and you should always confirm it by the spectral Doppler showing that arterial signal. So again, it is just a variation than normal, or is it associated? I mean, is it a Down syndrome baby? So we know that there was a great discussion a few years back that it is a marker for trisomy 21, the Turner's, the 22q deletion, duplications, even sometimes in trisomy 18 and 13. Should we offer an invasive testing? So if you see ARSA with other markers, obviously you will offer invasive testing. If you see ARSA with a dual marker, which is in the intermediate risk group, or then you will always advise for the invasive testing. Again, this was a meta-analysis study. This was done in, of course, 2015. So again, they have advised that there is insufficient evidence to recommend fetal karyotype in cases with isolated ARSA. But if the background risk is high, a full karyotype is recommended. As we know that the likelihood ratio of isolated ARSA is 3.94. So the decision to perform further genetic testing, maybe even NIPT or full karyotype in cases of ARSA, should be done in specific cases following a mathematical methodology. What can be simply done is you look at the a priori risk. Most of these patients have a 11 to 14 week scan with the dual marker done. So they have a certain a priori risk. Say it is 1 in 2,450. We say that the ARSA likelihood ratio is 3.94. Hence, the post priori risk is 1.621, which is in that intermediate risk category. You talk with the patient, you counsel the patient, and write in paper that the risks and benefits of the amniocentesis are explained to the patient. And then the patient can decide. what we do usually in cases of these minor abnormalities, you cannot say abnormalities as such, but the variations what we see is of course a detailed anomaly scan. Especially you should look at the thymus, the ductus venosus, the systemic venous variations, single umbilical artery, specifically look at anus, because I mean, not that there is a great association with this, but whenever the postnatal findings or postnatal reports talk about extracardiac abnormalities which were not detected in utero, it is many a times about these, anus problems or malrotation, intestinal problems, which we don't really pick it up antenatally so often. So then a decision about invasive testing can be taken on a case-based scenarios. Sometimes it is just not possible to do a very detailed scan. A patient who is obese. Yesterday we did a scan who was 120 kg. It is very difficult to obtain the normal views in such patients. Forget about these additional oblique views or looking at the anus or looking at other detailed anatomy of the fetus. So sometimes, depending on these case scenarios, you can take the decision of invasive testing. One size fits for all approach never actually holds true for most of these cases in fetal medicine. So to summarize, the arch anomalies, the vascular rings can be assessed completely on a fetal echo, especially using color Doppler, high definition flow, a radiant flow, and things like that. Systematic assessment of the upper mediastinum, that is the three vessel view, the three vessel trachea view, and moving still cephalad for aortic branches. Trachea should be identified, and then the position of aortic arch and ductus should be looked for. The coronal plane is useful for showing this abnormal configuration of the proximal descending aorta in the posterior mediastinum. So thank you. This is just a clip which tells you about the, normally how the arch develops. It develops from the three main arches, paired arches, and that is by the regression, and this you finally get your left-sided aortic arch. Thank you.
Thank you very much, ma'am. It was a very, very, very nice lecture. With this, I think without wasting time, we move on to the next talk by again Professor Mark on anomalies of the systemic and pulmonary veins. Over to you, sir.
Thank you so much, and congratulations, Dr. Alpana. That's fantastic summary. There was a question about, and I'll just touch upon it briefly, and we could talk maybe later, but in terms of very good questions from one of Dr. Balu's fellows, Dr. Balaganesh, about how we manage as pediatric cardiologists these rings, potential rings, if it's a right arch with a left ductus, but asymptomatic, or even a double aortic arch, but asymptomatic. It used to be that we would only diagnose these rings when they were symptomatic because we weren't picking them up prenatally. And so the thinking was, if you diagnose a double aortic arch or a vascular ring of any kind, they had to have surgery. But now we're following them, and there's no consensus I'm aware of, at least in our area, in terms of how aggressive to manage. So I generally, if there are no symptoms, I follow them closely, but do not intervene. Sometimes even doing an MRI as a baby requires, in our institution, intubation and anesthesia. So sometimes I put that off. If there's any concern, I put that off as well. But it's a whole area of discussion, how to manage these babies with potential rings or true rings that are completely asymptomatic. How aggressive are you? But at the very least, they all need to be followed up clinically. So
the two cases which I showed of double aortic arch also were all right till 2 years of age, and no intervention was done for them.
That's good, yeah, because of course the fear is we'd be missing something. They're asymptomatic, but they're developing some fibrotic changes in the trachea or the esophagus that may be challenging to, that may not respond to relief of the ring. So that's our big fear. But I feel as long as we're very careful, I think that's the right approach. But Dr. Balganesh, I think, mentioned one study suggesting that it's possible they may be asymptomatic. like with the double arch. But that's a whole area of discussion. I think it's at the very least we need to follow them closely and have a close relationship with the parents so that they know what to be looking for. Okay, so should I share my screen?
Sure, sir.
I haven't been clicking optimize. I'm going to try clicking for optimize, and you tell me if it's the same quality or if it's better or worse compared to before. Does it jumpy or is it good?
Actually, all your videos are playing well throughout, Mark. No problems at all. My end,
so this is
really
so
perfect.
this is okay now. This is okay the way I did it.
It's good.
Okay.
Good.
Okay. So now for a little bit, we'll talk about abnormalities of the systemic and pulmonary veins. Of course, this can be fairly complex, and I'm not going to be having time to go into a lot of complexity, but I'll go into the main things. This is a diagram that I think Dr. Baloo also liked from the same book by Wyman Lai, who's a colleague of mine now here in Southern California, showing the segmental approach, atria, ventricles, and great arteries, and the connecting segments, AV canal and conus. Of course, leading into the atria are the pulmonary veins and the systemic veins, and that's what we're going to be talking about. And as it turns out, a lot of time there are abnormalities with these in the context of complex heart disease and heterotaxy, but sometimes there's just isolated abnormalities of the pulmonary or systemic veins. Heterotaxy, this is a nice review of, and Dr. Baloo, I think later on is going to be giving a whole talk on this. Meryl Cohen in Jack Rychik's book has this nice diagram showing asplenia versus polysplenia. I honestly think probably it's not a binary function. It's probably a spectrum of disease, but it's useful to remember what goes with what. For instance, bilateral SVC we see with both, whereas interrupted IVC is mainly with polysplenia. Some people call it bilateral left-sidedness.
Sorry, Mark, can I intervene? Actually, I think you're not supposed to click on that optimize video because it was getting a little blurred.
Okay, then let me.
Yeah, so don't click on that optimize video because then the other presentation gets blurred. That's what the technical staff had told me yesterday. I think some of them are typing now that it is a little blurred. Okay, yeah, now it is clear.
Thank you. Thank you, Dr. Apana.
This is much more clear. Yes.
Clear now. This is very clear here on my screen.
Well, let's hope the video. Let me know what the videos too. But thank you. So here we can see TAPVR mainly seen with asplenia, not with polysplenia. Ipsilateral with polysplenia, not with asplenia. Again, there's terminology Baloo may be getting into. I call it polysplenia versus asplenia, but recognizing it's a spectrum. Common atrium, primarily seen in polysplenia. Univentricular connections, mainly in asplenia. And concordant VA connections, mainly in polysplenia. So these are just some things to keep in mind when we're looking at pulmonary systemic venous returns because, again, they're often a marker for more complicated abnormalities of situs. So let's talk about systemic venous abnormalities. This is just a situs looking at the important aspects of the abdomen, the descending aorta, stomach, and the IVC. Descending aorta just to the left of the spine, stomach on the left, of course, and the IVC anterior and rightward. And then as we're imaging, we always like to show that the IVC, when you turn it sagittally, and we do this even after birth, turn it sagittally and show the IVC draining to the right atrium. Very common, one of the most common systemic venous abnormalities is interrupted IVC, which of course is a marker for polysplenia or bilateral left-sidedness. And we could see that with a transverse cut here. Just looking on the left, you could see this prominent azygos behind the aorta. Now, an azygos can be a normal structure, but when it's dilated, it suggests that it's dilated because the IVC may be interrupted. So that's one clue to interrupted IVC. When you see a prominent azygos, you may not see an IVC where you should. And what else do we see in this left clip that's interesting? If you'll notice that the stomach is over on this side and the heart is on this side. So again, suggesting some type of heterotaxy, and the clue might have been initially that the azygos is dilated behind the aorta and that there's no IVC, interrupted IVC. And here you could see opening up sagittal, you could see the descending aorta and the IVC. The descending aorta in red and the interrupted IVC with the azygos. It's the azygos continuation of an interrupted IVC coming up and draining usually into the SVC. Very important to pick this up for lots of different reasons, for diagnostic reasons, but also after the baby's born. We just had a baby born with heterotaxia and we weren't sure if the IVC was interrupted, and it makes a difference in the cath lab in terms of access if we need to stent the ductus or things like that. So persistent LSVC we talked about before, and I think I've shown you these images. Very common, perhaps about 1% of the population. It's LSVC is draining to the coronary sinus. You could see it in cross section. Sometimes, as you see on the right, it can mimic the primum atrial septal defect when you're not at the plane of the 4-chamber view. But usually when you see a dilated coronary sinus, it's usually because of a persistent LSVC, which again is a marker, can be a marker for left-sided obstructive lesions like bicuspid aortic valve or coarctation of the aorta. And here again, the diagram I showed you before, very important because it's so common, particularly you can see this even with a normal coronary sinus, but particularly when there's an LSVC causing a dilated coronary sinus, it looks like a mitral atresia or a primum ASD when in fact you're just a little bit inferior to the plane of the 4th chamber, and you come up a little bit, the mitral valve opens up, and then you just see a circle representing the dilated coronary sinus. It's usually from an LSVC. If it's not an LSVC, what else would it be? It would probably be from anomalous pulmonary venous return draining to the heart, to the coronary sinus. So this is again from Tracy, just showing the persistent LSVC. You could see bilateral SVCs. This is the right-sided SVC. This is the left-sided SVC. You can see the PA and the aorta both coming to the left of the trachea, but we have 2 SVCs. So now I'm going to talk a little bit about, again, just touching base on some of the more common or important types of venous abnormalities. Now we're changing gears and talking about pulmonary venous abnormalities. The main one to be thinking about is total anomalous pulmonary venous return. I'm not going to talk much about partial. Partial anomalous pulmonary venous return is even more. TAPFR is very difficult, as you know. Partial anomalous pulmonary venous return to detect is very difficult, but can be a manifestation of scimitar syndrome, where you have part of the lung being perfused anomalously and part of the lung being drained anomalously below the diaphragm. And the marker for that is often mesocardia or dextrocardia. But I'm going to spend most of the rest of the time on this talk about total anomalous pulmonary venous return because it's been so difficult to detect, but I think there's been dramatic improvements in detection of TAPVR, maybe even more so than coarctation. And so I'm going to go over some of the clues for you so that you will not be missing cases of TAPVR, even though I don't show it. I don't know if I'm showing it here, but there's a very low detection rate for TAPVR around the world. 1 out of 10,000 newborn infants is born with TAPVR, and in India, that's 1,800 babies a year, if my math is right. So it's very challenging to detect both before birth and after birth as well. Oh, I do show it here. So here's this paper that I really like showing just overall prevalence and detection rates for congenital heart disease around the world. This is from just 2 years ago. And here's the TAPVR. The very best center picked up half, which is pretty impressive because most of the cases are well less than 25%. There's a couple outliers. Most places it's 10 to 20%. Some it's less than 10% detection rates for TAPVR when isolated. Of course, TAPVR, like other abnormalities of systemic venous return, can be associated with heterotaxy. And when you have other abnormalities, the detection rate will be easier. But even isolated TAPVR, it's important to detect because many of these cases are obstructed and these babies are very sick, particularly the infradiaphragmatic TAPVR. And so if we don't pick them up prenatally, but the chance of them coming to correct diagnosis and repair early or may not be as good as if we have, are not as good as if we make the diagnosis before birth. So how do we detect TPVR? It's really the 4-chamber view that really helps. This is a commercial for the 4-chamber view, back to the 80s, how important the 4-chamber view is. It's a normal 4-chamber view. What are the findings that we would see in a 4-chamber view if we have TPVR? Well, first, as Balu, I think, mentioned, we'll often see an increased distance from the spine or the decent aorta to left atrium. Here you can see it's a very short distance, but often that distance will be increased in the context of TPVR. And some of you may know why that is. It's because, of course, we often will have a confluence of veins between the decent aorta and the left atrium. That's called a twig sign. When we see that confluence, and I'll show you examples, it looks like a twig or a stick behind the left atrium. You often see it will be a bald left atrium with no posterior ridge, or what we call a Coumadin ridge. Sometimes people mistake this normal folding of tissue between the left atrial appendage and the left pulmonary vein. It looks normal. Some people confuse that in adults for a clot, and they start Coumadin, a blood thinner. That's why we call it a Coumadin ridge, even though it's a normal structure. If you have that structure, it means you have at least one pulmonary vein draining to left atrium, so you've ruled out TPVR. So it's a good clue. If you do not see it, then you need to be concerned for possible TPVR. So if you just cannot see any veins returning to left atrium, that's a concern. Now, if there's a very challenging to image case, that's one thing. But if you're used to seeing at least 1 or 2 pulmonary veins in a relatively easy to image case and you don't see any veins, of course, you need to think about TPVR. And then right heart distortion. So this emphasizes the importance always of trying to see at least 1 pulmonary vein draining to left atrium, even in low-risk pregnancies if you can. So here's some examples. Here's on the left, a normal. You can see that between the aorta and the left atrium, there's really nothing there. Whereas here, between the aorta and left atrium, there's an increased distance, and you can see this twig sign. You can see this line back here, this sort of twig. This is the pulmonary venous confluence. So that's a classic appearance. And then here's another case, another example of TPVR. You could see the twig, increased distance between decent aorta and left atrium with the confluence behind the left atrium. And again, is this a case of ketortaxy? Yes, because look, what are we seeing? It looks like a common atrium over here with an AV canal. So I showed you this earlier. It is possible to see all 4 pulmonary veins. All you need to do is see 1 pulmonary vein draining to left atrium, and you've ruled out total anomalous pulmonary venous return. It's useful to see 1 from each side, especially if you have mesocardia or dextrocardia, you're worried about partial anomalous pulmonary venous return, then you want to spend more time trying to identify all 4 pulmonary veins if you can. So a lot of times that will be the presenting feature sonographically of scimitar syndrome, is mesocardia or dextrocardia with partial anomalous pulmonary venous returns from the right lung. Here's the Coumadin ridge I was mentioning to you, that if you see it, you see this little structure sticking into left atrium. If you see that, it's a very useful sign that you do not have TPVR, because this is the normal, and here you can see on the right the pulmonary venous return coming into it. Because if you have this ridge that's between the left atrial appendage and the left lower pulmonary vein, if you see that, you know that you have at least 1 pulmonary vein draining into left atrium. And here you can see on the left, you see left pulmonary vein and the left atrial appendage over here on the left. And here you can see the core flow, pulmonary vein draining in, and the in and out flow in and out of the left atrial appendage. And then right heart disproportion, of course, can be a marker for cohort. It could be a marker for TPVR. But we want to get better at picking TPVR up than just using right heart disproportion. Cohort is even more challenging, I think, than TPVR, because TPVR now we have discrete ways that we can be better at picking it up. So total anomalous pulmonary venous return, as I mentioned, there can be for various types. It can be supracardiac draining up to the SVC. It can be infradiaphragmatic, where it obstructs almost always at the ductus venosus. It could be cardiac, draining to the coronary sinus, or it could be mixed, some draining superiorly, some draining to the heart, so on and so forth. The mixed type is usually prognostically worse because the surgeons like to have a big confluence, all the pulmonary veins coming back to a confluence. Nice big confluence makes for easier to correct that with a wide open confluence draining unobstructedly to the left atrium. If you have only some veins draining to confluence, that repair will be smaller, more likely for obstruction. So it's better to have TEPVR all to the confluence rather than mixed. So that goes into how we counsel. So infradiaphragmatic is the main one that's always going to be obstructing, that you really ideally will know about before the baby's born. Here you can see all of the pulmonary confluence and draining inferiorly to the vertical vein down below the diaphragm to drain. And here's some examples. You could see over on the left, you could see the vertical vein here without color. In the middle, you could also see, this one actually doesn't show it as well until you put color on, right? The one on the right without color, you don't really see it, but with color, you could see the red vein draining inferiorly. That's the scimitar vein draining, piercing the diaphragm and going in the same direction as the descending aorta. That is inferiorly. You should not have a vein going inferiorly. It should all be coming superiorly above, past the diaphragm towards the heart. This is, when you see this, it's a sign, and we teach this to our fellows looking at newborns. You do not want to have a vein coming down, piercing the diaphragm. And so this is a descending vertical vein obstructing usually at the ductus venosus. So these babies, all the pulmonary venous return goes through that vein, obstructs, and they have very low cardiac output. And prostaglandin does not help. It may actually hurt. And the only thing to do for these babies is surgically repair them. In some cases, you can palliate them by stenting the ductus venosus. It's a challenging thing. We've had some experience at UCLA. It's not always the most straightforward. But if you do that, you can decompress the lungs for a period of time and then undergo a safer surgery if things go the way you want them to. Here's the infradiaphragmatic TEPVR. You could see the descending vein, the red, obstructing at the level of the ductus venosus. Here's another case, you could addendal perspective, sagittal imaging showing the descending vein obstructing at the level of the ductus venosus. Again, so important to try to get better at picking up TEPVR. And I think it's actually a lesion that we actually can make a lot of headway on. This is the repair. This is on the left before repair. Then the repair is just opening up the confluence and attaching it to the left atrium, and usually ligating or dividing the descending vein. So supracardiac has all the veins usually draining superiorly to the innominate vein, draining to the SVC, back to the right side. So the repair is closing the ASD, of course. All these TEPVRs will have an ASD, usually, almost always, if not at least a PFO, and then joining the confluence into the left atrium. Now, infracardiac, the best example I have comes from Dr. Patkar from Sani from Bangkok, a good friend and colleague who takes beautiful images. And this is a case of, she shared with me a TEPVR to a coronary sinus. There you can see there's not a lot of right heart disproportion, but their coronary sinus is quite dilated, and with more imaging, you could see that all four veins actually drain to that confluence. TEPVR to coronary sinus rarely obstructs. It's rarely a surgical emergency. That's something usually you have some time to repair, and the repair is relatively straightforward because the veins are already draining to the left, to the coronary sinus. You just open up the coronary sinus and close the atrial septum, and the prognosis is very good. Prognosis actually for TEPVR that's obstructed can actually be quite good too, with prenatal detection. Without prenatal detection, the prognosis is very poor. So diagnostic challenge, this is a case of suspected trisomy 21. I put this in here just because you could see some of the pulmonary venous return here, but we only see that only the the left-sided pulmonary veins are draining here. It turns out in this case, the right-sided pulmonary veins were draining to the other side of this common atrium with the common AV valve. So this was suspected trisomy 21 because of the common AV valve, complete canal, but it turns out to be a case of heterotaxy without trisomy 21. And sometimes the pulmonary systemic venous returns can be a tip-off, the first clue that there may be an abnormality. So take-home points. First, the systemic and pulmonary venous anomalies can occur in isolation or with additional cardiac abnormalities, and sometimes may represent markers for heterotaxy. We have to remember the importance of image quality, angle of acquisition, colorful Doppler, and cardiac, and evaluating the heart while beating, not just obtaining a bunch of still frame images in terms of evaluating pulmonary systemic venous returns. Most cases of TPVR should not be missed prenatally. In most cases are missed prenatally around the world, but they really shouldn't be just because we've learned a bunch of clues, many of which I've just gone over. I think the key is getting good image quality, because otherwise it's hard to see these things. But once you get good image quality with right angles, it's possible to see. And it is true, I didn't mention, if you can't see things well at 20 weeks, this is a case for pulmonary venous abnormalities. It's easier to see sometimes at 30 weeks because of the pulmonary venous return, the percentage of cardiac output to the lungs may be optimal at 30 weeks, maybe up to 25% of cardiac output in some studies. So sometimes it's easier, you may be able to see the pulmonary venous return easier with follow-up studies. The prognosis varies with details of the diagnosis. And finally, counseling should be performed, of course, by a collaborative multidisciplinary team to provide the best counseling and management plan for the fetus once you have identified particularly pulmonary systemic venous abnormalities in conjunction with more complicated cardiac disease. So thank you very much. I don't know if we have time for talk or any discussion or comments.
Thank you, Dr. Mark. I think we'll take the questions once Dr. Bayu finishes with the next talk on heterotaxy.
Okay, so can you see my screen?
Yes, sir, very well.
Yes.
So there are obviously a little bit of overlap between what Mark just did, because heterotaxy, of course, is one of the important features of heterotaxy is abnormal drainage of both the systemic and the pulmonary veins. So in this, I'm actually going to have a kind of a algorithm towards diagnosis of heterotaxy and differentiating the two types. So what is heterotaxy? It is basically defined as a different arrangement of body structures, and it is something which goes beyond the heart. The cardiac involvement is only a part of the heterotaxy syndrome. There are other organs, particularly the abdominal organs, also may have a different arrangements. There are different terms which people use as synonyms for heterotaxy. The older terms used to be the cardiosplenic syndromes like asplenia, polysplenia, and now then it's a similar phrase is the isomerism syndromes. The British typically call them isomerism. The right isomerism typically describes the asplenia syndrome, while the left isomerism is the polysplenia syndrome. So what is the normal arrangement? So within our body, the normal arrangement is one of asymmetry. You have different kinds of arrangement for the lungs and other body organs. Typically, the right lung is trilobed, while the left lung is bilobed. And the liver is on the right side, and the stomach and the spleen are on the left side. So this is one of the dissections which Balaganesh did. We have the thorax with the right and the left lung with the heart in between, and the liver and the stomach bubble are also seen. So the right-sided structures are the liver, the inferior vena cava, the right lung, the right atrium with its appendage, while the left-sided structures are stomach, the aorta, the heart, the left lung, the left atrium with its appendage. So in isomerism, what we have is a mirror image or symmetry. So in right isomerism, we have two right-sided structures. The lungs look similar, the appendages look similar, the liver often will be in the midline, and there is asplenia. In left isomerism, we have two bilobed lungs, which are looking like normal left lungs, bilateral left appendages, liver may be in the midline, and we have often multiple spleens, which may not be easily picked up by ultrasound. So how do you suspect isomerism in the fetus? So that's our starting point. Various ways, because this may be picked up by different people scanning the fetus. Sometimes it may be people may note an abnormal position of the stomach and the heart, which are not on the same side. Sometimes we may find complex intracardiac defects. Sometimes, as Mark just now mentioned, the starting point may be an abnormal venous connection. And sometimes it could be even a rhythm disturbance in early scan, particularly heart blocks. So this is how we start off. So the approach to diagnosis of cardiac isomerism heterotaxy, we have to basically understand two phrases. One is a nomenclature. That is a characterization of the type, whether it is a right isomerism or left isomerism. And second is, of course, the prognosis, which depends on the intracardiac anatomy. So the nomenclature and the prognosis, very often they don't actually gel together. So there is often this conflict between the anatomists and the clinicians, because the anatomists focus on certain things which are practically very less relevance clinically, like, for example, the morphology of the appendages. So how do you differentiate between the two types? So in the right isomerism, as we saw yesterday, and that's why the anatomic understanding was important, we had an extensive discussion about the atrial morphology as well as the appendage morphology. I will discuss a bit more about the appendages in this talk because it is possible to image them in the fetus. Then the systemic veins. I think the appendages and the systemic veins hold the key towards the differentiating the right and the left forms. And the systemic veins in right isomerism, we have a very peculiar arrangement of the systemic veins called the juxtaposition of the IVC and aorta, that I will show the images, while in the left isomerism, we have the classical double vessel sign due to interrupted IVC. So these are the two clues, the appendage morphology and the morphology of the systemic veins, that we differentiate the two types of the isomerism between right and left. The stomach position, the liver position, the cardiac position, etc., are highly variable and cannot be used as a diagnostic feature to differentiate between the right and the left forms of isomerism. So we saw these slides yesterday. The right atrium typically has got two parts, the trabeculated anterior portion and a smooth posterior portion which receives the veins, and then the left atrium characterized by a more smoother appearance with opening of the pulmonary veins. And we saw the differences in the appendage morphology, a broad-based right appendage and a more finger-like left appendage. So this also I showed the classical difference, a broad-based right atrial appendage and a finger-like left atrial appendage. And so the appendages, the two appendages are not similar. And this also I demonstrated yesterday. So I'll skip this. So in isomerism, typically we have the appendages which are looking very similar. Now look at this picture. We have two broad-based appendages on either side and almost like a common atrium here. So this is a classical example of a bilateral right appendage. And here we have a more slender appendage on both sides here. And this is an example of a bilateral left appendage. So if you can actually image this, and this images typically come from when you sweep a little cranially towards the outflow from the four-chamber view, you can see this appendages coming up by the side of the two ventricles like this. At the AV junction, we can see the two appendages, and now we can clearly make out the symmetry of the appendages in these two cases. Now comes the systemic venous anatomy, and this is really, really important. And yesterday, both Dr. Alpana and me spent time on looking at the abdominal view to look at the relationship of the IVC and the aorta. So normally in a situs solitis, the IVC will be on the right side and the aorta will be on the left side. And the aorta will be posterior to the IVC. So in situs inversus, this becomes just the reverse. Aorta goes to right and IVC to the left, but the relationship will be maintained. In right isomerism, what we call juxtaposition of the IVC and aorta. Both of them will be on the same side of the spine. While in left isomerism, we have what's called the double vessel sign, a dilated azygos due to interrupted IVC. So let us see this. So this is a normal relationship. We have the stomach on the left side and the IVC is on the right and anterior, while aorta is left of spine and posterior. So this is extremely important to look at the relationship of these two vessels. If in doubt, we can put a pulse wave Doppler. Aorta typically shows a pulsatile waveform, while the IVC shows a continuous waveform. So this is a very, very important. It's a soft point, but it is worth looking at it carefully every single time. So now let us look at an example here. Here you have a heart. The stomach is on the left side, but look at where the aorta and the IVC, both of them are on the right side of the spine. So this is shown in the cartoon as well. So this is what is called the juxtaposition of the aorta and the IVC. And this is a very useful clue towards right isomerism. Now, the second type is the double vessel sign, which Mark has shown in these pictures. So here you see the double vessel sign in the abdominal view, and here you have the double vessel. In fact, there are three in there in the four-chamber view. The third one is a dilated esophagus, in fact. So, and when you see this, the diagnosis is that the azygos is unduly dilated, and it could be a clue towards left isomerism. So, the confirmation of left isomerism comes from the parasagittal views, where you see the IVC interruption. So, here you see the SVC entering the right atrium, but there is a complete interruption of the intrahepatic portion of the IVC. You find in the parasagittal view two parallel vessels running, aorta and azygos, and when you put color, you will find that the direction of flow is actually opposite. Aorta is away from the heart, while azygos will move towards the heart. And that's been shown, and this can be rendered very nicely using the modern stick imaging. We can see the dilated azygos draining into the into the SVC here. So we can see the dilated azygos and the descending aorta. And what is very important, and this is another very similar kind of a picture you find in infracardiac TAPVC, like what Mark showed. But in TAPVC, the venous channel and the descending aorta will flow away from the heart in both types. That is, the infracardiac TAPVC, the venous channel as well as the descending aorta will flow away from the heart. But in interrupted IVC, the azygos will move towards the heart, while the descending aorta will be away from the heart. So these are all very useful clinical imaging clues to differentiate two apparently similar looking structures. Now, the position of the stomach, the liver, and the heart is highly variable. And sometimes you can have stomach, liver in different positions. Midline liver is very, very common. And bronchial situs, of course, is very specific, but it's very difficult to evaluate this in the fetus. So to summarize, the differentiation between the two types of heterotaxy, the right isomerism and the left isomerism, can be done specifically using the appendage morphology if you can image those, but otherwise use the systemic veins as a useful clue. The juxtaposed aorta and IVC points towards right isomerism, while a double vessel sign with dilated azygos points towards left isomerism. Now let us look at the intracardiac anatomy. There are certain sort of characteristics which usually suggest the right and the left types, but sometimes these can be highly variable. Now, an unbalanced type of AV septal defect with a univentricular heart morphology is more commonly found with right isomerism. Left isomerism, usually we find balanced AV septal defects. Typically, the biventricular heart is more common, and the myocardium has a very spongy-like appearance, which I will show later. Outflow tracts, in right isomerism, the pulmonary outflow tract abnormalities are more common, while in left-sided isomerism, DORVs may be there. Sometimes aortic arch obstruction could be seen. And as Mark just now described, TAPVR is much more common with right isomerism compared to left. And sometimes you may find a partial anomalous pulmonary vein drainage in the left isomerism. But remember that none of these clues are absolutely sacrosanct for either type. So the intracardiac anatomy is highly variable. So let us first look at some examples. This is a four-chamber view showing an unbalanced type of AV septal defect. You can see a single valve, and which is predominantly committed to the right ventricle with a small left ventricle. So this is highly suggestive of the right isomerism. You can see the primum atrial septal defect also. So this is an unbalanced AV septal defect with small LV, more commonly associated with right isomerism. Now here you see a heart where you see there is an AV septal defect, and you see that there is significant bradycardia. The heart rate is very slow, and you see the ventricles, the walls have a very thick, spongy-like appearance. There's a large atrial septal defect, which you see here. So this is very, very characteristic of left isomerism. You have balanced ventricles with bradycardia due to heart block. So this is another example, again, a balanced type of AV septal defect here, but you can see the double vessel sign over here. This is again suggestive of left isomerism. In the first case, there is a bradycardia with heart block. In the second case, there is no bradycardia. However, the double vessel sign is very clearly seen over there. Another example again of left isomerism, you see a very large atrial septal defect, a common atrioventricular valve, and again you see the double vessel sign over there. And this is yet another example where you find a very complex intracardiac anatomy. You have a double vessel sign and almost a univentricular heart over here. And there is some amount of rhythm disturbance as well. So this is an example of left isomerism with a complex intracardiac anatomy and bradycardia as well. So, the intracardiac anatomy can be variable. Generally, a single ventricle type of univentricular heart is more common with right, but sometimes you may find that in left as well. Now coming to the right outflow tracts, and this is an example of a right isomerism. Here we have the aorta, which is anterior, transposed aorta. The PA is posterior. In fact, the PA is smaller than the aorta, as we can very clearly see. So this is an example of transposed outflow tracts with pulmonic stenosis, and this is a very typical feature of right isomerism. And in left isomerism, this is a very typical three-vessel view. In fact, when you see this three-vessel view, you can only have two differentials, either a dilated SVC or a small aorta. And there you measure the size of the aorta, and if the aorta is normal size with the dilated SVC, then you are straight away suspecting something wrong. The usual differentials for this kind of picture are only three. One is an interrupted IVC with dilated azygos, a supracardiac TAPVC, or a vein of Galen malformation. You can exclude the other two, and then you are left with interrupted IVC. And again, you see the dilated SVC here, and with the dilated azygos draining into the SVC. So this is very, very characteristic of left isomerism. Now, this is the clue which Mark showed. Apparently normal, not normal looking, but obviously you have an AV septal defect with a small LV. But look at the area behind the heart. You can see a common chamber between the descending aorta and the left atrium. And that is a common pulmonary vein chamber. And in this case, this was a drainage into the coronary sinus, a cardiac type of TAPVC. Another example of the same left isomerism, where you have a vertical vein draining all the way down to the portal vein. You can see not the difference not the color flow direction. If it was an azygos, then the venous, the flow in the venous channel would have been towards the heart. But in this case, it's a vertical vein. All the pulmonary veins have joined together and descending downwards towards the portal vein. So the direction of color flow is the same as that we find in the descending aorta. This was an example of an infracardiac TAPVC in the setting of right isomerism. Conduction disturbances like what we've seen here is common in left isomerism, mainly because in left isomerism we have a deficiency of the sinoatrial node, and hence often we have abnormal conduction, typically heart blocks. And typically this can occur very early in pregnancy as well, even in the first trimester. So it's a pretty bad prognostic feature for left isomerism. So this is a table which Mark showed. This is a paper which was published in 2016, looking at the various intracardiac anatomy in the two forms of isomerism. AV septal defect is seen in about 2/3 of both. Univentricular physiology is more common in right isomerism. Right-sided outflow obstruction is much more common in right isomerism. And TAPVR is practically seen in about 1/3 of right isomerism, while AV block is more common in left isomerism. And since there is atrioventricular block, the possibility of hydrops fetalis is much more common in left isomerism. First trimester diagnosis is possible, and some of the very rare pictures. This is a situation where you have the heart and the stomach in different places. There is AV valve regurgitation here, and there's a common, almost like a common AV valve which is leaking. There's a single outflow tract. These are all very suggestive of right isomerism. You have unbalanced AV septal defect with AV valve regurgitation and a single outflow. All of this point towards a pretty dismal prognosis for this fetus. And even worse is this, where you have very classical the appendage pattern which is found here. There is almost like a common atrium. You find an AV septal defect, balanced ventricles, but look at the heart rate, and it is really slow. And there's a lot of fluid inside the thorax suggesting effusions and hydrops. So this is a balanced AV septal defect, bilateral LA appendage, spongy myocardium, bradycardia due to heart block, high drops, very characteristic of left isomerism. And this is again a first trimester diagnosis. Both these first trimester diagnoses are really indicative of a very, very poor outcome. So when we talk about counseling, we talk about high-risk features from the perspective of prenatal counseling as well as postnatal counseling. Generally, the right isomerism, unless there is an AV valve regurgitation, they usually survive the pregnancy and they are okay. But the left isomerism, the bad features are heart block with high drops and AV valve regurgitation. So in general, a complex left isomerism generally tends to have a poor in utero prognosis. However, postnatally, the right isomerism is much more complex for the surgeon because typically they have unbalanced AV septal defect, TAPVR, so they need multi-stage complex palliative procedures. Often complicating features like extracardiac anomalies like biliary atresia also may be there. In left isomerism, if you have no heart block, balanced AV septal defect, usually the surgeons can handle it, but there is always a long-term risk of developing heart block in these patients, so they need extended follow-up. Again, from the same paper, a host of abnormalities, abnormal findings, the hiatus hernia. We have described a case of hiatus hernia with right isomerism, renal anomalies. Then in left isomerism, also a massive amount of gastrointestinal anomalies and so on. And both of them can have these things. So it's whenever you actually look at diagnose heterotaxy or isomerism, you need to look for the second anomaly, the third anomaly, the fourth anomaly, and so on. So we have to just really, really inspect the fetus very, very thoroughly to exclude all these associated problems. So survival estimates, of course, as I already said, the in utero prognosis is worse with the left isomerism, that is a blue one, while the right isomerism, once they survive the in utero period, the postnatal, they have a pretty long-term outcomes. So this is data from the Mayo Clinic in the US. So it's little older data. However, the late and results of modified Fontan operation for heterotaxy, this is one of the subsets which tend to perform not so well in the long run after the single ventricle palliation. So this and hypoplastic left heart syndrome are two of the lesions which usually have a relatively far worse prognosis after a Fontan, while something like tricuspid atresia tends to have a much better outcome. So all single ventricles are not the same. Tricuspid atresia depicts the much better end of the spectrum, while heterotaxy and HLHS are the worst end of the spectrum. So this is again the same thing, a lot of challenges in the long run with respect to the survival. This is data again, which shows that this 8-year survival in the more recent paper after Fontan was about 66%. So as these patients actually keep surviving and live longer, they face a lot of challenges in their lives. So this is a picture, so which is, imagine that this is the asymmetric face, which is really beautiful. But imagine if there is a perfect symmetry, it is not so good. So I think sometimes in life, asymmetry is better. And certainly for the heart, asymmetry is what we need. So thank you so much. And we will perhaps take some questions. And now we finished half an hour ahead. So we have enough time to discuss all the talks, questions relating to all the talks, and then move on to the next session, because I don't want to, my last time for Mark is 12 o'clock in my watch, because that will be 11:30 his time. So, I'm watching the time very carefully, but right now we are pretty much on time. So we can probably take some questions now. Thank you so much.
Right, sir. Thank you very much, Dr. Balu. Any questions for sir in the chat box? Because then this session ends. Even Dr. Alpana and Dr. Mark both are at hand to answer anything that you've come across in this session that you would want a further understanding or explanation. Anyone can please type in the chat box.
Okay, I have a question from Dr. Kiran, and he has been asking this question, quite a lot of questions. And this is regarding the prenatally detected TAPVC prognosis. I think both Mark and I can answer this, but let me just start. Now, since I completed heterotaxy, now, Kiran, the most important thing we need to do in this context is to rule out associated intracardiac anomalies, particularly heterotaxy, because very often and not than not, a TAPVC is often diagnosed together with other problems. If there are no associated cardiac defects at all, and then it's an isolated TAPVC, we are generally looking at a much better prognosis. Now, second question is then to identify the type of TAPVC. Now, if you diagnose an intracardiac TAPVC, you can take it for granted that it will be what we call the obstructed type. The pulmonary vein channel will be obstructed, and this baby will require surgery immediately after birth. 50% of supracardiac TAPVCs are also obstructed, and typically where the vertical vein ascends, it gets compressed under the pulmonary artery. So it is important for you to identify whether the TAPVC is obstructed. The clues will be: one, all intracardiac TAPVCs are obstructed. In a supracardiac TAPVC, if you see a lot of turbulent, high velocity flows in the pulmonary vein channel, it will be obstructed. Always refer such cases to the cardiac center for a planned delivery, because many of these obstructed TAPVCs will require urgent surgery. But the long-term outcomes are excellent. In fact, they do really, really well, because TAPVC is one of those lesions which can be corrected with excellent outcomes. So these are the important points to remember. Ensure that it is an isolated lesion, and then look for possible signs of obstruction using the clues I just detailed, and then accordingly plan. Mark, your comments, Mark?
So
I agree completely, Balu. For TAPVR, the key is to try to get better at prenatal detection, which I think we are getting better collectively. But then after birth, some of these babies with TAPVR, if there's no obstruction, we can wait a little time and let the pulmonary vascular resistance fall. Sometimes that's a little bit more favorable, but it's the ones that are obstructed that are really the key infants to identify prenatally, and then to deliver them in the right place. You don't want to have an obstructed infradiaphragmatic TAPVR delivered at some center hundreds of miles from where the surgery can be performed. So it just emphasizes the importance of prenatal detection, and I think we have some good clues that we've gone over today to help you identify these cases in the future.
So there's a question from Dr. Nidhi Bhatnagar. What is the status of brachiocephalic arteries with fetal echo scan?
Well, I think, sorry.
Yeah.
Was it brachiocephalic vein or artery?
Arteries,
Correct.
arteries.
Arteries.
Yeah.
Arteries, I think it is not really so important, except that in arch view, we always try and see the branching pattern. I mean, the three arteries arising from the arch are usually very well seen in the arch view. So we try and look at those three branches. Otherwise, as such, brachiocephalic in a normal arch probably not much significance.
But the brachiocephalic vein is important, because in the context of our discussion about
TAPVC,
if you find a very dilated brachiocephalic vein along with the dilated superior vena cava, it gives you a very strong clue towards diagnosing a supracardiac type of TAPVC. So the only other condition which can get this combination sometimes is a vein of Galen malformation in the brain. So it's a very, very useful clue. So when you have this 4 vessels in the 3-vessel view, you have differential diagnosis of persistent left SVC, then you have differential diagnosis of supracardiac TAPVC. Then, the dilated brachiocephalic vein is a very useful clue to separate the two. In persistent left SVC, typically the brachiocephalic vein is absent, because we have two SVC draining directly to the heart. While in supracardiac TAPVC, you have a dilated brachiocephalic vein. So it's a very, very useful clue. And now, in fact, I also forgot to show the brachiocephalic vein in the presentation. It's becoming a very important view in the fetal cardiac image.
Yes, like I said, still going cranial in the upper mediastinum, not just stopping at 3-vessel view, and still
Absolutely.
going cranial and documenting it in your fetal echo is a good practice point, you can say. Though it is not included in the fetal echo guidelines, I think everybody should practice that.
Yeah, and you had a nice diagram of that, Dr. Alpana. And also sometimes we see intrathymic innominate vein, which is just a normal variant, and you won't see that unless you go up higher, as we're saying. But I just wanted back to the question about the brachiocephalic arteries, as Dr. Alpana mentioned, it is nice to be able to pick up with even a left arch and an aberrant right subclavian artery by at the 3-vessel view, lowering the Nyquist, and you see the structure as Dr. Alpana showed very nicely, and that's a nice thing to pick up as it may be associated with other abnormalities, genetic or otherwise.
Any more questions? We wait a little while, or then we move on to our next session with Dr. Mark. Anyone can type in the chat box, please.
I think I think we should encourage them to put it in the question and answer, because there are two boxes simultaneously. We would encourage all the delegates to type their questions in the Q&A box. I think most of the questions which have been, has been answered today. Bala Ganesh has asked a lot of questions. I think he is really attending this with a lot of interest. He is, in fact, a very, very good expert. And I have to say this, that he has done some phenomenal work with systemic veins, published very heavily using this technology. In fact, maybe in one of the future sessions, I would like him to present his work on the umbilicoportal system. He has done some absolutely phenomenal work. And trying to get that work.
It is a very interesting and upcoming topic. There's a lot of work going on everywhere. We are also trying to accumulate the data and the cases and their outcome in these last 1 or 2 years. I think in the QA session, there is one typical question which everybody wants to know always for all these disease diagnosis. What is the basic machine requirements and what kind of machine details and for the anomaly scan and fetal echo. And I always say that the machines are important, but the man behind the machine is equally and more important. And that's what you learn during these conferences. But of course, machines are important. And of course, Balu showed images on very high-end E10 machine. But some of my images, if you see, they were really 10 years old, which were really on lower end systems, which were considered higher end at that time. But yes, with the knowledge, I mean, maybe your images may not be as good as, say, Balu's images, but you will be able to pick up the anomalies if your knowledge of that anatomy is very sound. So I think irrespective of machine, it is important to have that knowledge.
Man as well as a lady. I think a lot of ladies. I think, one thing which I may say, with all due respect to my cardiology colleagues, I feel that the imaging skills are very, very, very high with the fetal medicine, the radiology people. In fact, I was the whole interest towards imaging for me started from one of the sessions way back in Mumbai in 2005. Dr. B.S. Ramamurthy was there. And then I was wondering whether we can actually image the fetal heart this way. So that was the starting point. And then it is a learning curve. I think we need to, the whole aim of all these sessions is to generate this interest. And, the heart has become a pretty important target organ in prenatal imaging. The reasons are because, number one, we know that the congenital heart defects as a group are very, very common. And in fact, they are perhaps one of the most common types. The second thing is all over India, schemes are coming up. This is what I wanted to discuss before Mark leaves, because he did mention about the insurance, the healthcare, cover, politics. Now in India, there's a lot of political will, as well as the insurance and cover, etc. In Kerala, for example, the entire cardiac surgery, pediatric heart surgery, is now being run through the government system. It is the National Health Mission, called the RBSK program. This is being conducted in Kerala in the form of a scheme called Hrudyam. Hrudyam stands for heart. So anyone, any parent or any doctor, any pediatrician who has a patient with a heart defect now can actually apply online for the scheme. They can submit their reports. There is an expert panel of pediatric cardiologists who will be receiving these cases for an opinion. And we give this opinion. And depending on this, for example, if there's a transposition which needs urgent surgery, we can mark option within 24 hours action to be taken. Then in each district of Kerala, there is a district coordinator and officer who will call up the patient and coordinate the transfer of that patient to a cardiac center within 24 hours. And I have to say that this is happening quite beautifully. And now a large number of patients are benefiting through the scheme, especially the urgent and the transfer. The ambulance services are also provided by the government. And I believe more and more centers, states are going to take up this. And I would say that this is one of the major factors which played a role in Kerala reducing the infant mortality to below 10. Now the IMR in Kerala is about 6 or something. It is actually quite good. It is almost comparable to many developed countries. And I believe the scheme was executed. And I had the great honor to participate in the scheme and train the doctors, and following which the prenatal pickup is also improved and the whole machinery behind has improved. I think it's a very, very important message. And I am saying it as a prelude to my last talk, counseling talk, where I'm putting all these things into perspective. So it is quite possible. And that's why it's very, very important to diagnose the cardiac lesions, especially the correctable ones.
Is it only for the patients in state of Kerala, or there are patients outside also taking benefit through this scheme?
Basically, what is done is it is, I think, a partnership between the central government and the state government.
Okay, so
this particular scheme is for Kerala because both the governments are participating. But I think this kind of scheme is there in Maharashtra as well, because I understand Dr. Suresh Rao in Kogalaban is operating patients through the similar kind of a scheme. The RVSK scheme is a common scheme. That is why I actually want everyone who is diagnosing or suspecting problems, the way I would like to see this developing is, a preliminary level, somebody suspects, then refers to an expert like Dr. Alpana, who makes a diagnosis, then involves a pediatric cardiologist, and then the patient gets the care. And if we can actually collectively do this, we can actually optimize the outcomes. And that is where the whole beauty of prenatal diagnosis comes. And India is a very large country. We have something like 100,000 babies born with critical CHDs every year. And together, we can make a difference. This is my ulterior motive for conducting a program like this, And
one more question from Dr. Kiran. Quickly, if you can tell us any particular Doppler adjustments or settings to get good images and crisp color flow detection? If you could take this question. Yeah, Dr. Balu or Dr. Alpana, either one can answer.
Dr. Alpana?
Actually, as a prelude, we had put up a small video on how to adjust those color settings. Usually it all depends on the PRF or the color scale velocities and narrowing your box. I mean, you should narrow it to the structure where you want to see the flow through. Whenever we are focusing, when you do a focal zoom for seeing a heart structure, I always say that keep at least a spine in the view and then the 4 chambers so that you get the orientation. But for a color, you can, really narrow your box and put it across the structure which you want to see. The color Doppler signal will be picked up, when it is in line with the ultrasound beam. If you want to see the structures in black and white, say a septum, you will see it better when it is kind of parallel to the probe. And if you want to see the structures in color flow, like you're seeing the color flow in AV valves, then the regurgitation through the tricuspid, you will see it better when it is in the apical 4 chamber, because it is in line with that your ultrasound beam direction. Similarly, if you want to see the pulmonary veins as the transverse 4 chamber view, and then it will be seen very well. The rest of the adjustments, like, the persistence, then the filter, and, all this physics is usually set by the application specialist in the machine, say the color balance or a right priority, as some machines will call it. So all these are set. What is most important is to narrow your box, put it across the structure which you want to see, and adjust the angle, as Dr. Mark has always been pointing it to. If you want to see a VSD in color Doppler, a apical 4 chamber view is not really going to help. But if you put it across as a transverse four chamber view or a lateral four chamber view, it will definitely pick up the color better. So the best is to put it sometimes in that oblique direction and things like that. So I think that summarizes the.
There's a couple of more. One anonymous attendee has said the no ARSA sign, which is a novel method of prenatal screening for aberrant right subclavian artery, is probably what Dr. Nidhi ma'am was referring to. So your comments on that, on the no ARSA sign, either Dr. Balu or Dr. Alpana, anyone can take this.
No, I don't know whether no ARSA is basically we say normally. I mean, we always take a upper mediastinal view and then label it as this is a NARSA or a normally related, normal right subclavian artery. And we always document it. In fact, I do it for my anomaly scans or cardiac screening, what we call it, in all patients. So, yes, it gives you... it tells you that there is no, looking for the ARSA, you have to do certain adjustments. But if you always show NRSA, that is normal right subclavian, it strengthens your belief that, of course, this is a normal anatomy.
Dr. Pratik is asking, is there any, sorry, Dr. Balu, you were saying something?
One more point. What I have learned from someone else is that if you have other markers, like for example, echogenic focus, then that's the only other marker, I believe, or or maybe an AVST, which is a much more stronger marker. Then I also specifically write no ARSA. But otherwise, I don't know whether we should, for an absolutely normal heart, every time whether we had to write no ARSA. I'm not so sure.
Not in the report, yes.
Okay. There's a question from Dr. Pratik Joshi. The medico-legal aspects of fetal echo. Do we go for consent before screening about some limitations, etc.? Do we put it in the report or take a consent? Because it could have a medico-legal problem later if you miss something and then they come back to you.
Perhaps we can discuss this later.
Yeah,
it should be like a standard protocol for any prenatal imaging in India. Fetal echo is also a part of that, isn't it? So we should probably follow the same principles of PNDT, which applies to all the pregnancy scans. Dr. Alpana, I think you will be much better.
No, I think he's talking about those disclaimers or something because, partial anomalous pulmonary venous drainage cannot be picked up. Then certain forms of VSDs cannot be picked up. Sometimes parents come saying that my previous baby had ASD, and then we tell them that ASDs are always there in a prenatal life. And something like that, you miss that kind of a thing. So I think he's talking about that medico-legal aspect.
Okay, I think in that case, I have a disclaimer in my reports below my report above where I signed that some of these things like PAPVC, small VSD, bicuspid, coronary abnormalities. One rather severe lesion which we cannot diagnose is the anomalous left coronary from the pulmonary artery. That is actually a very important cardiac condition which needs surgery also. Then sometimes peripheral pulmonary stenosis, and then of course the secondum type of ASDs. So we put that line. If you really want to be very safe, then you can put that. And then I usually tell the parents also after a normal scan that look, we have done the scan, and then I also put no significant structural heart defects detected for the period of gestation. That is also important because like you do a 20-week scan and you report it as normal, maybe 28, 30 weeks you may find cardiac tumors. Sometimes you may find tachycardia typically happens in later pregnancy. So then they may come back to you and why this was not picked up before. So you should always put detected for the period of gestation. That is also good. So these are two things which we can always do. Put it as not detected at the period of gestation, and then the disclaimer saying which all conditions you can't diagnose. I think we can probably move on because it's 10:45. So I would definitely want Mark to take advantage of that little, ahead time we have now, 15 minutes. Maybe you can do the quiz in a more interesting, a more detailed way after the cardiac function. So I want Mark to enjoy that extra 15 minutes if possible.
Okay. Thank you, Balu. This is a great discussion, and I appreciate all these questions that are being asked, and the discussion has been very interesting and very informative, just the discussion too. So what my next talk now is on what? Is on
cardiac function. Sir.
Cardiac function. Let's see. So you'll let me know, please, if
Yeah, you got this.
let me know if the what the clips are looking like, if it's smooth or not.
Yeah, this is smooth, sir. We can proceed.
Okay, great. Okay, so this will be talk about fetal cardiac function, and I'll admit to you in the very beginning a disclaimer that I tend to be more of a qualitative sort of person. Unless there's some concern, something specifically abnormal, I generally tend to focus on very, very high quality qualitative assessment, very good imaging, image quality, and angles, so on and so forth. Qualitative, and then if there's an abnormality, to go to quantitative assessment. Not everyone feels the same way, but that's my bias, just to put out there. But there are some quantitative ways to assess cardiac function that are new. I'm going to be speaking specifically about speckle tracking that I find to be very exciting, which says a lot because I'm not sort of a quantitative sort of person. So I wanted to put that out there in the beginning, just to be clear. So now I'm just going to talk about what do the guidelines say in terms of cardiac function evaluation. These are the AIUM guidelines that came out in 2018 for fetal cardiac screening. And these guidelines were also endorsed by these other societies, including American College of Radiology here in the United States. In 2018, these screening guidelines do not include any evaluation of cardiac function at all for screening, which I think personally, I differ. I'm contrary to these guidelines. I have a personal bias for routine qualitative evaluation of ventricular function, even at the time of routine screening, even though it may not be called for by the guidelines. Now, fetal echo guidelines, these came out, these are the AIUM 2020. Qualitative assessment, for the most part, although as I mentioned to you before, the newest guidelines that came out in 2020 do ask for pulse Doppler of the across all 4 pulmonary valves and 1 pulmonary vein from each side. So that's a sort of a quantitative approach that has been added to fetal echo, and you can see that here at the bottom. I think you could see that. So I'll move that. That's sort of been added on in 2020, this sort of quantitative approach. And my approach is a little bit different from that. I don't personally feel a need for routine quantitative evaluation of ventricular function, even the pulse Doppler of the pulmonary veins, pulse Doppler across the valves. Even I'm not convinced that it's time best spent. And it's clearly opinion-based recommendation with some data, but this is controversial, but I want to share my own opinion about it based upon all my years of experience. But why should we evaluate cardiac function, either qualitatively or quantitatively? Why should we evaluate function? Well, to evaluate prognosis, sometimes it's useful, sometimes to facilitate detection of congenital heart disease or other fetal pathology, to evaluate candidacy for or response to fetal intervention, to evaluate the likelihood of requiring early neonatal intervention, to improve, and then finally to improve our understanding of fetal cardiovascular function in normals and in the presence of congenital heart disease or other fetal pathology. So this is a case of, oops, wait a sec, go back. Tricuspid atresia is on the left and hypoplastic left heart or mitral atresia on the right. Both you could assess qualitatively the ventricular function, but of course, it'd be nice to be able to prognosticate how these ventricles are going to do long-term. We tend to feel, and the data suggests that single right ventricles do not do as well in the long term as single left ventricles. It would be nice to be able to look at the fetus and prognosticate which ventricle is going to go well for many, many decades and which not. Right now, we're sort of limited, but I think there's a lot of potential to be able to evaluate and prognosticate long-term ventricular function better than we're doing now. And then detection of heart disease, Coarctation of the aorta, as we've talked about, is very difficult to detect. We generally want to look, some of the best ways to detect it include sagittal imaging of the aortic arch with measuring of the isthmus or the angle between the ductus and the isthmus, things that are very difficult to do even at time of fetal echo, and certainly are not part of a screening exam. But it's conceivable evaluating cardiac function, say at the four-chamber view level, may be able to help us detect coarctation of the aorta or other defects. And actually, Greg DeVore, and I've been working with Greg DeVore and his work with speckle tracking, showing that there may be actually some hope with speckle tracking in terms of helping us to detect coarctation from a four-chamber view. So there's lots of different ways to assess the heart quantitatively and qualitatively that we're not using. I'm going to focus this talk on speckle tracking because I'm fortunate enough to work closely with my friend Greg DeVore. Many of you know his work from decades of pioneering work in the field. But we've been able to be doing a lot of work together, led by Greg, on speckle tracking. This is a quote by Steve Jobs: "A lot of time people don't know what they want until you show it to them." And this is the case for me for speckle tracking. That it's a way that we can start to see things that have been there all along. In other words, if you look at the heart on the right, you could see the heart squeezing, and you could say, yeah, the function looks pretty good. Right ventricular function, left ventricular function looks pretty good. But I think many of us have not dug down much deeper than that when we do our routine screening. And speckle tracking, I think, is a way to help teach our eye to see things that we haven't been seeing before. So this is work that we've been doing with Greg DeVore, as I mentioned. He's published many papers in this area using speckle tracking. This is a slide showing how you track different speckles along the endocardial surface of both the left ventricle and the right ventricle. Starting, we track the right ventricle during systole, then during diastole, and then do the same thing for the left ventricle. And then with the software, it divides the ventricles into 24 different segments from the base all the way to the apex. And then we could see here the right ventricle and left ventricle divided up in those different segments. Number 1 here at the base and number 24 down at the apex. And that could be very useful then, even just with these qualitative assessments. This type of speckle tracking gives qualitative as well as quantitative assessment of cardiac function. I'll start talking about qualitative assessment because, as you know, that's where my heart lies. With every routine scan, you should be at least qualitatively assessing the ventricular function. If you look on the left, you could see the heart moving. If you look on the right, you're going to start to see the left ventricle, the endocardial surface on this, the septal surface, the apical area, the free wall. Same thing for the right ventricle. You'll see how the right ventricular septal surface moves during systole. On the left ventricle, what happens at the apex, very different at the LV apex compared to the RV. Just looking at this one schematic, you can learn a whole lot about how a normal heart works. Now, it is true that one normal heart may have a very different type of schematic and speckle tracking sort of cartoon than the next, but still there's a pattern that emerges over time by studying even just these cartoons that help us see the heart move in ways that we haven't seen it before. So for me personally, it's been very exciting just in terms of teaching my eye how to see things I just haven't seen before, not even thinking about quantitative assessment, even just a qualitative assessment. And these are some ways that have helped me with this, just seeing the endocardial border moving on the left. Here you could see in yellow, each speckle that's tracked, and then you see in the green how that speckle or that part of the endocardium moves during systole and during diastole. And then here on the right, you could see actually the vector, the velocity that the direction and the speed that each speckle is moving throughout the cardiac cycle. And these can be studied, take a lot of time even for normals, just to see how the heart moves in normals. And there's still a whole lot to do in this area, a lot of research to be done, a lot of learning to be done in normals. And then, of course, in abnormals, to understand pathology, pathologic function, to understand how to detect subtle abnormalities in function that we've been missing all along, and to quantify them in many cases as well, to help learn to understand cardiac dysfunction and learn and find ways to treat it. So here's a case of biventricular cardiomyopathy with some tricuspid regurgitation. We could see on the left the function's not quite right, but if we use speckle tracking, we can see in 2 different types of cartoons, we're able to see the cardiac function in ways. Look at the septal motion of the LV, how impaired it is, actually paradoxic in some areas. You can see this portion of the LV is not moving very well. You can see the free wall of the RV very poorly moving. There's a lot of areas that we can learn just by looking at these schematics, and after we do this, then sure, you can go back and look at the 4-chamber view itself and in retrospect see that. But sometimes it takes work with speckle tracking or other techniques to train our eyes to see things that we haven't been looking at before. So here's a fetus with a pericardial effusion. We generally don't look at the function that carefully, but sometimes the pericardial effusion can impact the function dramatically. Here you could see the dramatic hyperdynamic function of the LV free wall, how the septum is moving abnormally, both in the LV and in the RV. And it takes some time, but we can look at these schematics or diagrams and learn about how the heart is moving abnormally in ways that we cannot so readily see just with our eye looking at the conventional 4-chamber view. So that's all the qualitative assessment, but there's a lot there, a lot to learn that we still have yet to learn, even with normals. From a qualitative assessment, what parts of the septum, what parts of the free wall, what parts of the apex and base move in what ways, RV versus LV, and so on and so forth. But the fact is, speckle tracking is also a phenomenal tool. This approach, this 24-segment approach to speckle tracking, makes it very easy, relatively easy to get a lot of quantitative data. Before I move on, remember though that whenever you do quantitative assessment of the fetal heart, you need to make sure that it's reproducible, and it's not going to be reproducible if the image quality isn't good and if the angle of acquisition is inappropriate. So you really need to optimize the image quality, because ultimately we're going to need to track the endocardium during systole and diastole for both ventricles, and if you don't see that very well, you're not going to have reproducible and accurate quantitative data. So there's lots of different things. I'll just go through it pretty quickly, but it's a tremendously powerful approach. Once you do this tracing, not only do you get those nice schematics that I show you for qualitative assessment, but there's a huge amount of quantitative information. This is just ventricular sizes and looking at the ventricular widths and ratios at the base. The LV, of course, is over 1 because the LV is a little bit bigger. The RV is a little bit bigger than the LV, and as we get closer to the apex, it goes the other way around. The LV being a little bit bigger at the width at the apex than the RV, so we can get these standardized quantitative assessment of widths of each ventricle. We can compute severity index of the length to the width of both ventricles. At the apex, if you consider the length to the width at the apex, the width is very narrow, so the severity index is very high. As you get towards the base, it's very low. But of course, if in case of pathology, the severity index of the RV or LV or both may be abnormal, and we could quantify that as well. We also can look at different forms of ventricular contractility. There's longitudinal, helical, and circumferential contractility. We can look at global contractility in terms of fractional area change. We could look at transverse contractility in terms of fractional shortening at each of the 24 segments. We can look at longitudinal strain for longitudinal contractility, or we can look at longitudinal displacement, fractional shortening, or basolateral and septal wall annular plane systolic excursion. So all these types of quantitative assessments can be made after the simple tracing of both ventricles using speckle tracking. Just go through here's fractional, for example, the fractional area change. You could the program can, after you do the tracing, can tell you here's between end diastole and systole, give you the change in fractional area of both ventricles. We can look at transverse contractility for each of the 24 segments. Of course, the transverse contractility or shortening fraction is going to vary from the base to the apex. In general, we haven't been so precise and sophisticated when we do fractional shortening, but this is a way for us to be much more precise and sophisticated and reproducible. And here's the 24-segment transverse ventricular fractional shortening. Over here, from the base to the apex, you can see the right ventricle. The fractional shortening doesn't change that much, whereas the left ventricle, as you get towards the apex, there's much more squeeze, it's much more hyperdynamic. You could see that with the schematics as well, that you see much more motion that's effectively inward at the LV compared to the RV. And all that can be quantified. Longitudinal contractility can be in the form of, you're probably all familiar with TAPSE and MAPSE, annular plane systolic excursion. That could be quantitatively assessed with speckle tracking. Annular plane systolic excursion, we can do this with speckle tracking as well, and we can come out with quantitative assessment. This is speckle tracking the basal, lateral, and septal wall annular plane systolic excursion of the right and left ventricles. We can see here, this is for the left ventricle, the lateral wall compared to the septum. The lateral wall moves much more than the septum. Same thing for the right ventricle. The lateral wall, annular plane systolic excursion, how the base moves towards the apex much more at the lateral wall than at the septum. And if we're looking at right ventricle and left ventricle at the same time, you can see the RV, annular plane systolic excursion, is much greater than the LV. That's true for the lateral wall as well as for the septal wall. So we're able to dig down deep and qualitatively and quantitatively evaluate how the portions of the base at the level of the AV valves moves towards the apex in ways that we haven't done before. The global longitudinal strain also can be computed just from the simple tracing of the LV and the RV. And as it turns out, this longitudinal excursional fracture shortening actually correlates with global strain. So as we do more and more quantitative assessments, some of those overlap. And so we may not need to be doing all these quantitative assessments, but some of them actually correlate with each other. But given all of them together, it gives us a bigger picture of the cardiac function qualitatively and quantitatively than we have just by eyeballing the heart and looking at how the heart squeezes. Of course, we could also look at left ventricular cardiac, more standard indices of left ventricular cardiac output and ejection fraction, stroke volume, cardiac output, that we can calculate based upon the numbers generated from speckle tracking from that simple tracing that I mentioned to you in the beginning. So, but the truth about speckle tracking can be applied to other areas in general. And when we talk about a qualitative assessment of function, in theory, qualitative assessment, there's an ease of acquisition and interpretation, right? We're just looking at how the heart squeezes qualitatively. It's very easy to acquire and interpret, but in truth, it's challenging sometimes to acquire the four chamber well enough to evaluate the cardiac function, even qualitatively. And it's challenging to interpret reproducibly when we're talking about qualitative assessment. Is it moderately reduced function? Is it moderately reduced function? It may vary from an observer to observer. So it's challenging, but the key is getting good quality imaging to begin with. So even qualitative assessment can be challenging. How about quantitative assessment? In theory, quantitative assessment, one of the benefit is that it enables conversion of a subjective or variable acquisition and interpretation into objective reproducible parameters. It's not just qualitative and subjective. Now it's objective and reproducible. But the truth is that quantitative assessment is very challenging to acquire well and challenging to measure reproducibly, particularly if the image quality is not optimal. So here's some more a case of perils of quantitative assessment. I think I mentioned that I may talk about this. This is a 21-weeker. This is a real case seen by pediatric cardiologist diagnosed with tetralogy flow. Then I saw as a second opinion for the patient was considering termination of the pregnancy. So these are some actual images of the fourth chamber. You could see obtained at the time of the diagnosis. You could see here the this is a 4-chamber. Image quality is not so good. It looks like a big dropout here because, again, we're not looking at a clip and we're not looking at a correct angle, but there's lots of measurements of different sizes and structures. Here's that dropout I mentioned too. This is being measured above the aortic valve. So this is the normal dropout, but clearly I think this was felt to be a VSD. Here you could see the clip. It looks like a big aorta over here and a PA over there. The angle's not so bad, it's just the image quality is not so hot. And over here, same thing, image quality is not so hot. Here the PA looks okay, just not seeing things well. But here on the left, the aorta does look a little bit big. But the image quality was not so great. Here's the ductal arch on the right, and here's trying to look at here. I think they were thinking maybe some override here, but again, image quality not so great. But instead of spending more time to optimize the image, more time was spent on quantitative assessment. Lots of different quantitative variables were obtained, all sorts of different things that we might want to look at, because there's so many things we could quantify if we wanted to, and spend the time looking at all of these different things, parameters, Tay index, ejection time, blah, blah, blah. But the bottom line is the diagnosis with tetralogy, because the image quality wasn't good, and yet it was a normal fetus. These are images that I obtained by I didn't spend my time to get quantitative measurements. I spent my time to get really good qualitative assessment of the heart, optimizing the image quality and the angles of acquisition, and the heart looked normal. And the baby was a colleague of mine that we trained when I was in San Diego, saw the baby postnatal, and the baby did have a normal echo after birth. So the message being, in this case, the very important image quality and angle of acquisition that I've been talking about a lot during this conference and much before. You saw the case of the ascending aorta dropout that's above the aortic valve, so that's not a VSD. And the perils of quantitative measurement, again, you need first to optimize image quality before you want to start to spend time doing quantitative measurements, but always be very careful. You need to optimize image quality before you make the diagnosis of significant congenital heart disease. Now, I must say at the same time, sometimes quantitative data are very important, and this is a case where I learned my lesson. This was a 21-weeker scene, but it looked like the left heart was small. I mean, the right heart was small, hypoplastic right heart with compensatory dilation of the left side. The aorta looked prominent here. The left ventricle, the right ventricle just was a little small. This was at 21 weeks. Here's a little bit later on, third trimester, and it looked more exaggerated. The right ventricle, tricuspid valve looked a little small. The left heart looked big. And we were just thinking hypoplastic right. But I don't know if any of you know the correct diagnosis by looking at this. I didn't show you all the data, but this was a case of Marfan syndrome. And had we done, I was thinking it's a small right heart, but really it was a big left heart. So the message is always, and this is another paper written up by Dr. Anu Whitney when she was with us at UCLA. Had we done Z-scores, even though I was thinking it was the right heart was small, the fact is the left heart was big. And how do you tell the difference? Well, you do Z-scores. You measure them and you see. And had we done that, you'll see even at 21 weeks, the aortic root was dilated even in the very beginning, right? At that image I showed you. And very soon thereafter, the mitral valve and the aortic valve were also markedly dilated, well above a Z of 2, whereas the right-sided structures were all normal. So in cases where things do not look quite right, of course you need to do very reproducible, high-quality quantitative measurements. But when things are normal, maybe less important, but always whenever we do quantitative measurements, we need to optimize the image so that it's reproducible. So take-home points from this talk. Every fetal cardiac evaluation should include assessment of function, in my opinion, even though it's not in the guidelines. Some of our guidelines in North America for screening do not include assessment of function. That should explicitly be recommended, in my opinion. Both qualitative and quantitative evaluation of cardiac function require high resolution imaging and reproducible measurements. Even if it's just qualitative assessment of function, you want it to be a reproducible image of the LV squeeze, for instance. So you really need high quality imaging, even if it's just qualitative assessment. speckle tracking techniques enhance the power of qualitative and quantitative assessment and can teach us how to see, even just with 2D imaging, elements of cardiac function that previously have been overlooked by all of us, I think. And in the years to come, speckle tracking and other techniques, I think, will likely improve our understanding of fetal cardiac function with tangible clinical impact. I think it'll really make a difference. But just like with 3D, 4D, the beautiful images that Balu is showing us today, speckle tracking techniques are not easy, and there's long learning curves to do it really well and to do it in a reproducible fashion. And that's going to be true for other quantitative techniques as well. So just a little quote from William. It's been attributed to William Bruce Cameron: "Not everything that can be counted counts, and not everything that counts can be counted." It's very telling and very apropos. And I think that's it. I don't know if we have time for discussion or questions, but thank you.
So we can take some questions. So if anyone's willing, please can you type in the Q&A or in the chat box, and we'll take some questions before we move on to the very exciting fetal echocardiac quiz that Dr. Mark has created for us.
I actually, I loved that, the pseudo tetralogy case, with so much of measurements and so many things. In fact, this has happened here as well in real life. In fact, it was an opposite scenario. A lot of measurements of LV measurements, LA iota ratios, ejection fraction, fractional shortenings and stuff like that. And the transposition was missed. So, it is essentially, I think, we have to go this stepwise. Many people find fetal heart function difficult, but it's going to be very important in future because I think Greg has come up with a lot of data about how this may be an additional clue towards things like coarctation and so on. And later on, when we offer treatment, therapeutic options to these patients, like arrhythmias or in utero interventions, serial assessment of some of these parameters become important. I think the Z-scores, which Dr. Alpana mentioned yesterday, are very important. I would request all delegates to use that measurement and Z-score before they say this iota is small or this PA is big and so on. So I think it's become, we need to become more and more objective. So these are my comments.
Yes, actually we get a lot of requests for fetal echo just because somebody has said that PA looks mildly smaller as compared to aorta, and then I can't say that it is mildly smaller or slightly smaller or the other structure is mildly prominent. And here we definitely need to say the Z-score, and then we can authentically say that no, this is normal. And though it is eyeballically small, it is actually not a small structure. We get such requests for fetal echo.
Yeah. And I appreciate Balu mentioning that I think this can happen to all of us, doing a lot of quantitative measurements or not, and then missing, either overcalling a defect or missing a defect. It can happen to any of us. But my message is that we should really focus on optimizing the image quality and the angle and the image quality before we start focusing on other quantitative measurements, just because I think it's going to pay off much more. And if you don't have really good image quality, it's a waste of time to be doing the quantitative measurements.
Dr. Nidhi Bhatnagar has asked the same question, actually, Z-scores as well as pulsed Doppler values. Your thoughts?
We discussed this, isn't it? So maybe, Sanjeev, we can move on to the quiz because I'm looking at my watch, 11:15. That must be 10:45 p.m. Mark's time, isn't it?
That's right, yes.
Yeah.
So this is the fetal echo quiz, and I'll just explain a few ground rules to everybody. So Dr. Mark has set us 12 questions. The first two of these will be, of course, he'll be explaining. There'll be no prizes for that. And but after that, the next 10 will have prizes like a gift voucher we're going to give out to the person who types in the correct answer in the chat box. It has to be the complete answer and the correct answer. We would like your name to be displayed in the chat box when you're typing it. Of course, we see most names. A few of people have logged in anonymously, so it's going to be a little tough for us to guess who that person is. So you can log out and log in back. We still have a few minutes, and come in with your name so we know who's answering the correctly, basically. The one who answers first correctly will be getting the prize. There'll be only one prize per question. So, Dr. Mark, I think that's good enough to start. We can start with the first two, which you can explain to us. And then from the third one onwards, once you say, type in, tell us your answer, then we'll expect answers to come in the chat box. Yes?
Yeah,
right.
and the winner will be announced at the end of the program.
Yes, we'll just review everything. We'll hope that the people who are answering are actually delegates. Okay, so only registered delegates will be getting the prizes. So we'll do a check, and towards the end, at the end of Dr. Balu's lecture, the last lecture, we'll be announcing the prizes both for the quiz as well as for the papers and poster competition.
Okay.
Yes.
So I'm very excited here, and I'm not even taking the quiz, so I'm very excited. So can you all see?
Yes, sir. This is looking fine.
Okay. So yeah, and then hopefully everyone will give us their feedback in terms of how we can make this even better for this particular format. But Sanjeev, thanks for coaching me through it. But the first two will just be practice. Yeah. So what is this? This is case number 1. I think there's 12 cases.
You can lead us also, Dr. Mark. Yeah. Yeah.
So this is a structure within the right atrium. Here's the tricuspid valve. This is a structure flopping in the breeze here, but here it seems more doesn't move as much, and you can see the same structure here. Here's the IVC and the hepatic veins. This is in the right atrium coming down from near the SVC. Here you could see it coming down from near the SVC, this prominent mass within the right atrium.
Yeah. So we have the correct answer from Dr. Pradosh Kumar Sarangi. He answers Crista terminalis.
Ah, very good. Now, but does that doctor, he or she does not get a prize, does he?
No, perhaps we can manage one, I think. Yes.
Okay, that's very good. That's right, exactly. Crista terminalis. That's exactly what it is, and sometimes it's very prominent, just like what we call the Coumadin ridge in the left atrium can be very prominent, but it's a normal structure. Wow, very good. Okay, and this is this is a 36-week twin fetus. Can you tell? Hard to tell because it's not moving, right? Now is it normal? So I don't see, I have this full screen, so I'm not seeing the responses, but hopefully people are seeing that this is a case of twin with severe biventricular cardiomyopathy with tricuspid regurg on the right. And in fact, if you look carefully at the LV apex, it looks like there's a thrombus. Here you could see it enlarged. You could see what looks like a thrombus in the LV apex, and very trabeculated, poorly functioning RV and LV. And this is a fetus who, unfortunately, this was not present at 20 weeks. We went back. The maternal fetal medicine doctor had very good scans at 20 weeks. It was perfectly normal. This developed between 20 weeks and 34 weeks. And ultimately, unfortunately, this baby passed away after birth with no genetic cause identified. But severe cardiomyopathy. You need to see the heart beating to be able to pick this up. Okay, so now, Sanjeev, now this is...
Yeah, we start with the prizes, sir.
Okay, so here we go. Is there a ductal flow abnormality? So I can't, Sanjeev, I can't see.
Yes, sir. We are waiting for the answers.
Anyone get this? Should I go ahead?
No, we just wait, sir. One.
Okay. So you can look at the 2D on the left, at the core on the left. could look at the pulse Doppler waveform, and you look at the pulsatility index.
So we got answers like retrograde flow in the ductus, TAPVC, right side aorta, coarctation aorta, premature ductal closure, reversal in aortic isthmus, MAPCA, coarc, interrupted aortic arch, double aortic arch. These are the answers we got so far.
Well, those are great. I mean, that shows it's not completely straightforward. The right answer, can I give the right answer? It is. Is this okay time?
That's it, sir. It's, I think we are getting similar answers again. Premature ductal closure and coronal diverticulum, ductus dependent pulmonary stenosis. These are the answers we got.
Yeah. So those are all great. And this is premature. This is a ductal constriction. We call it ductal constriction or premature ductal closure. If you look on the left, this is a tortuous ductus, which is very common third trimester. But it doesn't always have evidence of premature closure or ductal constriction. So it's blue, and then it goes red back, and you could see the continuous red flow, and you could see that the nyquist is all the way up. So you need to make sure the nyquist is all the way up, otherwise you'll have false positive runoff. And then over here, you could see a lot of flow throughout diastole. It sort of looks like a coarct. As pediatric cardiologists, we know what a coarct after birth looks like, this continuous diastolic runoff. This is what ductal constriction looks like, and we could quantify this with the pulsatility index, which looks at the peak divided by the min, divided by the mean. And here, because the diastolic velocity is increased, the pulsatility index is decreased. Normally it's 1.9 to 3 throughout gestation. This is like 1.5. This decreased pulsatility index, there's less pulsatility because you have higher diastolic velocity with ductal constriction. So this is a case of ductal constriction or premature ductal closure. You always need to ask about if they're taking aspirin or Advil or other NSAIDs or a lot of polyphenol in their diet. But this is a case of ductal constriction, which often is completely benign, but can cause heart failure. You start with pulmonary regurg, and then tricuspid regurgitation, and then in some severest forms can develop significant heart failure.
So we can give this to Dr. Raj Bezdadia. He answered premature ductal closure. That should do, right?
Yeah. Yeah. That's great. Okay, so case number 4, 22 weeks. You could see the left ventricle and the right ventricle. See there's some tricuspid regurgitation over here, but that's not the diagnosis. There is some tricuspid regurgitation. Now at 37 weeks, that was, I think, 22. Now we're up to 37 weeks. Here's the 4-chamber view. Here's the tricuspid regurgitation. Here's the velocity. Any ideas?
We're waiting for answers, sir. We've got inlet VSD mainly. There's Dr. Sujata who's come up with this plastic tricuspid valve.
Very good. Very good. That's exactly what this is. It's initially all we saw was that the tricuspid valve did not really look dysplastic. It looked pretty normal, but there was a little bit more tricuspid regurg than we normally see, and even with the nyquist all the way up. That's at 22 weeks. At 37 weeks, the tricuspid regurgitation was much more severe, and you could get a sense over here that the tricuspid valve is a little dysplastic, but it's not Ebstein's. It's not apically displaced. And the velocity is actually 3.5. The velocity of the tricuspid, the higher the velocity, the higher the RV pressure is, so that it's not a weak right ventricle, it's actually a strong right ventricle that is generating high pressure. And here you could see the pulmonary valve opening and closing. That's also reflective of a right ventricle that's still healthy. So the prognosis of this was actually quite good, even though there was significant progression of the amount of tricuspid regurgitation during the 3rd trimester. And here after birth, you could see the tricuspid valve. It's only mildly dysplastic here, but there you could see there's a fair amount of regurgitation still. and the velocity has dropped because the pulmonary vascular resistance has fallen. So this is actually a patient who actually did quite well. And here's, you can see there's still some right to left shunting across the atrial septum because of all the tricuspid regurg, which would make the baby a little bit blue. But the pulmonary valve is opening well, and the ductus arteriosus now is all left to right. So the pulmonary vascular resistance has fallen, and the prognosis is actually quite good. And in these cases, the tricuspid regurgitation can actually get better after birth with time as the pulmonary resistance falls because the right ventricular afterload falls, so there's less need for the tricuspid regurgitation. Okay, ready for this one? Are we ready for the next one, Sanjeev?
Yes, sir, we can go forward. That's quiz 5.
Okay.
So it's taken us 3 seconds to get the right answer.
Okay.
It's multiple. The first one who's typed in is Amog Avinash Jagtap. Yeah.
Very good. Yeah. So this is a case of Epstein's anomaly because we could see the tricuspid valve all the way down towards the apex, the septal leaflet here, coaptation point all the way down here. The right atrium is very big. These patients are at risk for fetal atrial arrhythmias. They're at risk for SVTs. Sometimes there's WPW. And they're at risk for right ventricular outflow tract obstruction. There's so much tricuspid regurg, there's not as much prograde flow across the pulmonary valve. So here's actually the pulmonary valve here on the left. You can see the pulmonary valve is not opening. And in fact, in this case, there was continuous retrograde flow throughout the cardiac cycle, not just diastolic, but even during systole and diastole, continuous retrograde flow from the ductus across the pulmonary valve into the right ventricle. So this is a case of what we call a circular shunt or a complete right heart flow reversal. That can be an ominous sign in fetus with Epstein's or tricuspid valve dysplasia. And some institutions have tried treating this with non-steroidal anti-inflammatories to constrict the ductus to eliminate the circular shunt. And it seems like that may be helpful in some cases to optimize survival of these fetuses. These fetuses are at risk for demise because of progressive heart failure. And even after birth, the prognosis is somewhat guarded. This is, we actually have seen similar pathophysiology in recipient twins in twin-twin transfusion syndrome. And this is a case where Dr. Raman Schmeit did ablation of the communicating vessels, and the circular shunt completely reversed within days after the procedure. Unfortunately, with Epstein's and tricuspid valve dysplasia, it's not such an easy fix. But that patient with Epstein's did very poorly and actually got septic following delivery and did not do as well as we would have liked. Okay, ready for an interesting case. Case number 6, left axis deviation. I think everyone can see there's left axis deviation. Spine's back here. This is sternum up here. Here's the heart, and this is the left. This is the right. And this is the left ventricle. This is the right ventricle. This is a very challenging fetus to image. Each time is very challenging to see everything really well because of the baby's position. It's very hard, especially to see the pulmonary arteries and some of the outflow tract areas was very tough. So we didn't know what was going on through most of pregnancy. I kept sending it back to the maternal fetal medicine doctor saying, are you sure there's not a hernia or a pulmonary mass or something pulling or pushing the heart? And they kept saying no. And then third trimester, we finally figured this out. And this is on the right, this is a hint. This is a normal, and this is the fetus we're talking about.
We've received the absolutely correct answer. This is from Ashok Bharti. and he's called it absent left lung.
Very good. Yeah, it took us a while to figure that out, but now this was like, whenever you see extreme left axis with the apex directed completely posteriorly, think absent agenesis of the left lung until proven otherwise. Because I've seen 2 of these cases and they both looked exactly the same. And I haven't seen anything else that does that extreme form of left axis. Now, I could tell you what was happening during the pregnancy. We kept seeing the PA. Remember I talked about earlier that ideally the MPA should be trifurcating. You may not see all 3 components in the single plane, but you want to make sure you see an RPA, LPA, and a ductus. Well, in this case, it was just a challenging scan, so I never saw 3. I just figured, well, I'm just not seeing the ductus. I'm seeing the RPA and the LPA. I just can't see the ductus. Maybe there's no ductus, or it's small, or I just couldn't see. Here you can see on the right, you really want to see an RPA, LPA, and a ductus. And in this case, I just saw what I thought was an RPA and an LPA until I finally figured this out, that this is actually the RPA and the ductus, and there is no LPA. So that was the lesson I learned towards the 3rd trimester. And this is after the baby's born. You can see the RPA. And usually the LPA would be coming right here, but there is no LPA in this baby. So I'm following this baby. The baby, some of these babies are at risk for pulmonary hypertension. This baby has not developed, is now a child, somewhere between 5 and 10 years of age, doing really well. So, all right, so I want to know if...
Sanjeev, just one quick, I think everyone should type their answers in the chat box and not in the Q&A box.
We've said that, so we are only looking in the chat box. So, yeah.
In the Q&A also, please type answers in the chat box.
Please type in the chat box. We are not looking at the Q&A replies. Only in the chat box, please, because that's where the flow is coming. Okay. Yeah, so you can go on.
Okay. So I don't know how we'll do this. There's 3 different cases. Are they VSDs or not?
You can go on. It's not a problem. You can go on. Yeah.
I'm sorry?
You can go on as you would have otherwise. No problem.
Okay, here we go. Well, this one I think I've shown you before, but is this an outflow tract VSD or not? And we can go. So the answer to this, should I give the answer now or wait till the end?
I think you give it at the end of all, sir. Yeah.
Okay. Now this is the second case. This is all the same fetus. I'm just showing it. This is, I've been focused so much on doing always relatively perpendicular for VSDs, but when you're using color for like tricolor, like for tetralogy of Fallot, that sort of thing, sometimes color can be useful even from this angle. It's definitely useful from the other angle as well, but sometimes color can be useful in terms of the Y sign with tetralogy. So here's, or an outlet VSD. So here's back at the 4 chamber in the middle, and then a little bit higher up, and then up here to where you see the the right ventricular outflow tract crossing over at the end of the clip. Then here's the third one. This is all the same case. This is the third case here.
You can pose your question also.
So the question are, so we have 3 cases. Are they all VSDs or none of them VSDs? That's the question. How many of these cases are VSDs? And I can go back now once people answer. Should I go over it now? Do we have the right answer yet?
Yes, we've got Dr. Supratik Basu who has said all VSD. This was a little muddled one, but it's okay. We'll still give it to him, sir. Yeah.
Okay. Yeah. So this one that we talked about earlier, this membranous VSD, partially occluded by tricuspid valve tissue. This one, you can see, you do not see the VSD on the first clip. Second clip, you can see, you're starting to see, even though we're at the level of the aorta, we're already seeing this shunting right here. If you look at the right, you could see that the PA is actually much more anterior, a little bit a different area. And this turned out to be actually a small membranous VSD. So this was actually a real defect. Because ordinarily we should not see the flow here. We should wait until we pull all the way to the right and superiorly the way it looks up here to see this crossing. And then this last one, in the middle, you could see this pretty obvious that there's a large outlet VSD here. And here on the right, you could see the color going across with the blue going across into the aorta. And even here on the first clip, you could see you could see blue flow going across in the very beginning of the clip right here. That's separate from the RVOT, the PA. See how there's two different jets, two different areas. Very similar to that other case. So these are all outlet VSDs. Again, this was a tough baby to scan because the placenta was anterior, maternal habitus, and there's no fluid where we wanted it, but we still got some reasonable pictures. So all three of these were real VSDs. So this one, I'm not sure how we'll do this because there's a bunch of different abnormalities. Sanjeev, I don't know how we'll
give it to the one who comes closest to this answer.
Okay. Yeah, and can give the overall idea. So here's the first clip. And after we go through the clips, we'll go over them again. We're getting some, okay, good. So I'm going to go to the next. I've shown you this already. Just see. And now the third clip. This is the last clip. Looks like we've got very good answers. So I'm going to go back. And the answer is, people are calling it right isomerism. Of course, there's different terminology, right isomerism or asplenia. Yes, because if we're looking at this first clip, we're going to see the twig sign, right? So suggesting TAPVR. There's a single AV valve. It looks like maybe a common atrium with a complete canal with a single ventricle. And then what else? We could see that the heart's over here and the stomach is over here. It's very brief, but you can see at the beginning of the clip, stomach's on this side, heart's on the other side. And and you could also see a structure next to the aorta on the same side as the aorta. Here, of course, this is obstructed infradiaphragmatic TAPVR. And here we can see it. This is an aorta. This is an anterior aorta coming off the RV. So it's either DORV or transposition. The pulmonary arteries are very hard to see. They're hypoplastic and there's no pulmonary valve. There's pulmonary atresia. So the answer, probable asplenia with right side of stomach and levocardia with single ventricle with DORV or pulmonary atresia, obstructed infradiaphragmatic TAPVR and hypoplastic pulmonary arteries. So this is a probable asplenia or right-sided isomerism, right atrial appendage isomerism, depending on how the terminology you'll use, with complex congenital heart disease. So I think we had a few people who got this completely correct. Is that right?
Yeah.
So we just search out the winner at the end. So this one went
right.
Nobody got everything right. That's the point, because I think the key elements of this diagnosis is unbalanced AV canal, single ventricle with TAPVC and pulmonary atresia. I think all three are very important.
Yeah, yeah, right. So it's a complex, just along the lines that Balu was talking about in his talk of heterotaxy, important to put everything together. So, all right, oops, that was too fast. Okay, ready for the next one?
Yes, sir. Quiz 9.
Number 9, get ready. Ah, haha. Okay, I think we got it right, someone.
Yes, we got it, sir. I think Raj has got it right.
Yeah.
Raj Bezdadia, that's the second one he's got right.
Yeah, very good. Yeah, yeah, very good. So that's this is a sweep from the 4-chamber to the 3-vessel view, showing that it's a rightward aortic arch. 3-vessel view, beautifully showing that it's a rightward aortic arch. So you need to think about the George syndrome. And this may be the only manifestation of the George syndrome in the fetus. So there are cases that have this, that have been missed, and then the baby's born with the George syndrome, and the parents are not happy that it was missed. There was a particular case that I was aware of in our area.
I think we can give it to 22q11 is the same as DiGeorge, so I think that point may be noted.
Yeah.
The same.
So Harish, we can give it to. Okay. We can split it, sir. That's all right.
It's actually put in the same time, yeah.
Yeah.
All right, so we have 3 left. This is a 23-weeker referred because of a pericardial effusion. Very good. I think people are getting this.
We got. I think Advait Takle has answered LV aneurysm. Sir.
Yeah. There was discussion after the baby. You could see that there's a defect in the ventricular, in the LV free wall towards the apex, with flow going in and out. But there's also, it's a circumscribed area. Whether or not there's a diverticulum or an aneurysm, we could talk about in terms of whether there's contractility or not. We actually had differences of opinion even after the baby was born. It turned out that technically it looked more like an aneurysm than a diverticulum, but that's what this was. This was probably some congenital infarct causing the defect to occur in the free wall of the LV, and this is the baby after birth. And actually, we just followed the baby for couple of years, but then the baby started having more and more arrhythmias, ventricular arrhythmias, and the orifice between the LV and the aneurysm was getting bigger. That would be less likely for a thrombus, but more likely to affect cardiovascular function, still a possibility for a stroke. And already the baby was developing arrhythmias. So we talked about transcatheter closure. Then we talked about surgical resection. Then we talked about whether that should be done from the outside or from the inside. And we ended up looking at doing a CAT to see where the coronaries were to help figure it out. And ultimately, we did go and do surgery to resect the aneurysm and to close the defect. And following the baby at this point, doing well. But it's a controversial area when to intervene and for what parameters. And the baby still has an arrhythmia, and we still need to follow this baby. But these are not that uncommon to have these LV diverticular or aneurysms from some congenital infarct that causes this hole or defect to develop. Any other comments on that, the panel? No. Okay, so here's we have two more cases. 3-vessel view, is it normal or not? But if it's not normal, you have to say what's wrong. We have very smart people in this course, taking this course.
Pankaj Ropre has got this.
Yeah.
Answered AP window.
Yeah, this is an AP window. Very good. People can say this is an AP window with, you could see this, the aorta, this is the PA connecting through the AP window. And some cases of AP window, there's no ductus. This was an AP window with no ductus. Here you could see the aorta on the right, and then the PA with the communication to the aorta, but no V because it doesn't continue on as a ductus. And then I wanted to see where the PAs were, so I just did individual imaging to, here's the ARP, you can see the ARP PA on the left clip, and you can see the LPA here on the right side of the clip. So the PAs were separate from this AP window. It seemed a little longer than the typical window, but when the surgeon went in, they felt it was sort of a straightforward AP window, even though in utero it looks more elongated. So yeah, this is the best way, guys. For whatever reason, things happen in 2s or 3s. I was following two pregnancies at the same time with AP windows, one with a ductus and one without. But what was common in both of that, the best way for sure to pick up the AP window is the 3-vessel view. So that's another great strength of the 3-vessel view, is it's the best way to pick up an AP window in utero. Just get used to what a normal 3-vessel view should look like, and then when you see an AP window, it'll be very obvious to you on the 3-vessel view level. And this is just color flow. You can see the thymus. You can see the AP window here. And there's no ductus. All right, so this was a real case that I thought was interesting, that our sonographers started scanning and thought the aorta was a little dilated. So I wanted to see what you think. And these are clips that he got, and then I went ahead and scanned a little bit more. And I used two hands to scan, pushed a little hard. And again, I tried to optimize the angle, because the angle was okay, but I just wasn't seeing the outflow very well. I wanted to optimize the angle. So here we've optimized the angle. It's just by pushing harder.
I think Dr. Meghna has got it right. She has answered top.
Okay.
Meghna Patkar, yeah.
Yeah, but you could see here, just by getting the angle a little bit more perpendicular, optimizing the picture a little bit more, it was tough. This is what we call a shallow VSD. Some tetralogies, that the VSD is much deeper. This is pretty shallow, so we could see why it's very hard, and our sonographer is very good to not pick it up initially. And I wasn't sure, but then I got these views which really clearly made it look like you could see the aorta override. In some views, they're just going back. You could see here, it's hard to see the override from this angle. But you can see that the aortic valve was a little bit bigger than the pulmonary valve, and the ascenior was dilated as it is with tetralogy. But the message is, again, trying, especially if things just don't look right, the aorta looks big, really try your best to get perpendicular, to get really nice, to open up, to get the answer, essentially. So that's great. Everyone was doing really well. I'm very impressed. And again, I always use the foot pedal. I would highly recommend trying this if you're not, just in terms of using two, so you can use two hands, free up both hands to hold the probe, get really great images. That's my strong recommendation. And then the foot pedal allows you to do that, allows you to acquire the clip, so you don't have to take one hand off to acquire the clip. And again, just to mention one more time, our symposium, anyone who wants, we're doing this again virtually this year, but hopefully we'll do it in person in the future. And I just wanted to close again by saying what a pleasure it's been to join all of you around the world. I wish it could be in person, hopefully soon. But for now, it's been quite an honor to join my friend and distinguished colleague, Balu, and my new distinguished colleague, Dr. It's just such a great pleasure to be working with both of you and to have been here today, and I guess so last night with all of you. So thank you. It's been a pleasure. Thank you for your attention.
Thank you, sir. Thank you for being with us.
You.
Had a wonderful time listening to you. Thank you for having a marathon Saturday, actually. You need some rest now. Yes.
And Balu achieved his goal. It is almost 11:55 here, so.
I think we are perfectly on time. It's 11:30 in the night for Mark. Mark, thank you so much for this absolutely wonderful contributions throughout the day for you, from the early in morning in California to almost midnight. You really put in so much of insights. I think the quiz was so beautiful. I enjoyed it so thoroughly. We are getting excellent feedbacks from everyone. Overall, I think it's a great success. And as we have discussed, I think there's a lot of scope for this kind of interactive kind of training, which is very important. And we will look forward to more and more such sessions with you in future, and more collaborations. And thank you so much.
Thank you, Balu. And also, I think we have permission. Dr. Balu and I are been talking about doing a project together that we're very excited about, in terms of an educational project that we'll work on together, that we're confident will be very well received to help people with learning how to evaluate the fetal heart in ways that have not been available before. So we're going to keep it a little secret, but we decided we wanted to mention it, and Balu, mention anything else if you want to, but we're really excited to work. It's such a pleasure and honor for me to work with Dr. Balu, and we're excited about this project. Balu, do you want to say anything else?
Yes, I think we will probably keep it a little bit close to our heart now, because we have just begun it, but it's going to be something which is very special. And we believe it will help a lot of people, because it's going to be completely a learner focused kind of a project with a lot of interactive learning, which we will come out with this hopefully during the Sonobuzz event in November. We can try to make some announcements, more concrete announcements, but you will hear something from us in the near future. Thank you so much, Mark. It has been an absolute pleasure to be with you throughout. And thank you very much. Probably now you need a richly deserved rest, and wake up late tomorrow. It's a Sunday for you, and get some really good rest before Monday begins. Thank you very much. And Sanjeev.
Thank you, Balu, and thank you again for your fantastic talks.
Thank you, Matt.
Alpana, thank you for your fantastic talks. It's such a pleasure to have worked with you as well.
Thank you, sir. Bye-bye.
Bye. Bye, Mark. Good night. So we will continue the sessions as per the schedule. Okay, so now the next, okay, right. So now the next one is the arrhythmia. Let me just get the presentation on my desktop. Just give me a second. Okay. I just need to, just give me a second.
Yes.
I got engrossed with the quiz that I forgot to open my next presentation. That's all. Okay, here we go. Okay, so this is regarding the fetal arrhythmias, and I'm going to have this as a continued session for the tachy and the brady. So just like, even though this is not intended as a quiz, but I would like to maintain some level of interaction with the audience. So whenever I ask a question, you are most welcome to sort of type in some of your answers to some of the common scenarios. So this is, we'll do it as an interactive session. So fetal arrhythmias are fortunately not so very common, but then it raises a lot of stress onto the people who on the person who's evaluating the fetus, because many people get confused and they are not able to come to the right diagnosis, and it becomes a real headache for many. Most of the arrhythmias are benign. Sustained arrhythmias are just about 10% of the total. But however, if you miss a major fetal arrhythmia, it can cause a real catastrophe. Now, the first rule of the thumb is that tachycardia is typically present in the third trimester, usually 28 weeks plus, while bradycardia can have an earlier presentation. This is not the absolute, truth, but it is generally a rule of the thumb. Now, the high-risk groups where you can suspect arrhythmia is whenever there is a hydropic fetus or an irregular heartbeat. Then if there is a setting of a maternal autoimmune disease like SLE or anti-ROLA antibody syndrome, we'll come to that later. Or if there is a family history of a previous child with a complete heart block or an arrhythmia, then you should suspect this. Usually, the presentation may be with reduced fetal movements. There could be history of maternal thyroid anomalies or autoimmune anomalies. There could be a positive family history in some of the genetic arrhythmias like long QT syndrome. And usually, they are picked up by irregular heartbeat on a routine scan. Sometimes there could be reduced fetal movements, non-immune height drops, or it can occur as a part of an associated heart defect. Now let us come to the diagnostic evaluation. The first part of my lecture, I will cover the how to evaluate an arrhythmia, and then we will go on to the case scenarios. There are 3 steps. The first is to evaluate the fetal heart rate, which is pretty easy. And the core of arrhythmia evaluation is the evaluation of the cardiac rhythm. And then we move on to the evaluation of structure to rule out any associated heart defects, and briefly about cardiac function. So fetal heart rate is very easy. You can use any site wherever you can put a Doppler on a vascular system. As a cardiologist, we usually prefer the LVOT, and we get the rate, which is the ventricular rate. And I prefer a single beat calibration, especially in arrhythmia. It is less confusing. Most of the machines have 2 beat automatically, calibrated. You can always change the setting. I prefer a single beat calibration. Now, this is very important. This is the evaluation of the cardiac rhythm. When you talk about the rhythm, you are talking about the atrioventricular relationship. And this is usually done either by using an M mode or using pulse wave. Both are useful and both often give complementary information. The M mode was the first technique which was used especially in the cardiology practice. And here you actually what is called an atrioventricular M mode, get both the simultaneous sampling of the atria and the ventricle. Here we can see in the M mode, which is depicted, the atria are shown by A on the top and the ventricles are on B. And you can see that every atrium beat is conducted to the ventricles. You will also notice that there is a small delay between the atrium and the ventricle, which is a time taken for the impulse to travel across the atrioventricular knot. So that is a normal finding. So you don't have a vertical line, but rather you have a slanting line. In difficult cases where the fetal position is difficult, now some of the new machines have the anatomical M mode, where you can rotate the cursor and get a simultaneous atrial and ventricular activity recorded like what I have shown here. So this is something, the cursor, the red cursor, you can rotate it whichever way you want to get a good recording. Then the pulse wave Doppler, many people use this instead of the M mode, because I know that a lot of people do not use M mode. It's a very good, useful tool, M mode, so you should learn how to use it. Now, the pulse wave Doppler, the preferred site for the evaluation of the rhythm is the LVOT. So you record what is called an LV inflow-outflow method. And that's what I'm going to demonstrate here. So this is the LVOT. You put the cursor just below the aortic valve, and you get something like this. You get an LV inflow-outflow Doppler. On top of the inflow, you see the two waves of the mitral inflow, the E and the A waves, and here we have the outflow. A good practice is to increase the sweep speed. Then you can see the waveforms very clearly, the E wave, the A wave, and the V wave here. And then you can actually calculate the AV interval also. That is, the AV interval is 123 here, which is within the normal range. So by this, we can actually get a lot of information. We can calculate the heart rate and see whether it's in the normal range. We can study the atrioventricular relationship and see whether every atrial activity is followed by a ventricular activity. So E. And then third, we can also measure the mechanical AV interval. So a lot of information from the simple technique. Then there is another Doppler, which is sometimes used in the evaluation of the rhythm, which is the SVC aorta Doppler. And here, this is an example of the SVC aorta Doppler, which is recorded in the three-vessel view. Here, what happens is that the retrograde A waves can be recorded in the SVC Doppler along with the systolic flow in the aorta. So the atrial contraction causes that small reversal in the SVC, which is recorded as the A wave here. And then the V is the ventricular V. So here what we can do is we can actually calculate the A to V interval and then the V to A interval. And this is important in elucidating the mechanism of tachycardia, whether it is a short VA tachycardia or a long VA tachycardia. This will show examples later. Instead of the SVC aorta Doppler, you can sometimes use the LVOT, the pulmonary artery, pulmonary vein Doppler, and so on. But this is one which is mostly described in the literature. Now, besides the assessment of the heart rate and rhythm, you also do an overall comprehensive assessment of the fetus, looking at parameters like presence or absence of eye drops, study the characteristics of the venous Dopplers, look at the heart size, cardiac function, umbilical artery Doppler, and then there is a CVP score, cardiovascular profile score, described by James Huta. And then less than 7 is okay, but if it is more than 7, more than 7 is okay, less than 7 means that the fetus is compromised. Now, while you evaluate the fetus for the possible arrhythmia, don't forget to look at the mother. And one of the very, very useful practices is to look at the thyroid profile of the mother. And very often, a rhythm disturbance in the mother, in the fetus, may be actually the reason how a thyroid anomaly in the mother is actually picked up. I always ensure that the maternal electrolytes, renal functions, etc. are done, including the maternal ECG, if we are actually planning to treat the arrhythmia. Okay, now let us move on to the specific conditions. So broadly, we can classify arrhythmias into 3 groups. The first is just a simple irregular heartbeats, which are the atrial and ventricular premature beats. Then we have tachycardias, which are defined as a heart rate of more than 200. And bradycardias, some people use 180 cutoff also, but I prefer 200. And then bradyarrhythmias, which are typically with the fetal heart rate of less than 100. So this is how we broadly classify. Let us start with tachycardias. So the first question is whether the arrhythmia is sustained or not. So you may have to actually see the patient, for about a longish period, 30 minutes. Sometimes if there is an arrhythmia, you may want to call them back after a study in between and make sure that the arrhythmia is sustained more than 50% of the time during a 45-minute study. If it is not sustained, then we are mostly going to consider ectopics. So let us now move on to that. So this is the first case, and once the case is over, we can, before I do the analysis, the audience can actually, type in some of their answers as well. And this is the spectral Doppler of the LVOT. You can see something happening. It's not a very regular event. It's something happening. The couple of maybe 3 beats, there's something abnormal happening. And this is the M mode evaluation. And if you look at the atria on the top and the ventricles on the bottom, you can see that something is happening. So that's given a clue as well. That's the abnormal beat. So what is the rhythm disturbance in this particular case? The audience can participate by typing in the answer, but there are no clues, no prizes for this, just to keep the audience engaged, because we can see that with arrhythmia, the participation also is dropping a little bit. So this is, now we move on to the analysis of this entity. This is an example of atrial premature beats. Atrial premature beats. So let us look at this. That's the abnormal beat. There's another abnormal beat here. So atrial premature beats, there are two types. The Sanjeev? Actually, I can hear some disturbance.
Yes, we can hear some disturbance in the background. It needs to be blocked.
I think somebody has to mute their mic, please. Okay. So the atrial premature beats, there are two types. The first type is what is called a conducted beat, and the second is what is called a missed. In a conducted beat, what happens is there is an atrial premature beat which will be conducted to the ventricles. So in this case, what we saw here is an example of a conducted beat. So these are the normal beats which are shown in white bars, and now we have an atrial premature beat which is conducted, which is shown in the red bar. And when this happens at a regular frequency, then it becomes a kind of an irregular rhythm. And then we have the normal beat. So here we have, again, frequent ectopic beats, multiple ectopic beats, and all of them are conducted as well. So the characteristic feature of an ectopic beat is the presence of the varying RR intervals. Here, all the N's are the normal beats and the E's are the ectopic beats. And you can see that the RR intervals are widely. There's a lot of disturbance in the background. If somebody can look into it, it will be nice. So you see that when you look at the intervals, it's varying from as high as 550 to 360. So this is a very characteristic of the atrial ectopic beats.
We can just wait for a minute. So just wait.
Yeah, I think Dr. Subhash is
Dr. Mani.
Yes. So we can.
Hello.
Can I continue?
I think there's still some noise coming.
I'll just get it organized. Just one moment.
Yeah, Dr. Mani. Hello. Okay, fine. Yeah, just tell me. Acha, my audio. Oh, 1 minute. Yeah, sorry.
Yeah, I think now you can continue.
Yes, sir.
Okay.
It's fine, sir. Thank you.
I think we had some music in the background. That helps because arrhythmia is also about a little bit about music as well. So it doesn't matter. Right. So we covered atrial ectopic beats. The examples which I showed here were all the situations where the atrial ectopic beat were conducted to the ventricles. And we will see example of the missed beats later on. Now look at this M mode here. You see here an abnormal ventricular beat here. So that is the abnormal beat. And you see that between these two beats, this is actually moved closer in. So ventricular premature beats are pretty much uncommon. And usually they are seen in association with conditions like cardiac tumors or sometimes myocarditis, or then this rare anomaly called long QT syndrome. It requires a lot of careful assessment to look to differentiate between atrial and the ventricular premature beats. But the key thing is that in the ventricular premature beats, the atrial, the AA intervals will remain a constant, while you find this additional ventricular beat, which is actually, with the varying VV intervals. So that is how you actually, evaluate the ectopic beats. Now let us move on to the absolutely more frank fetal tachycardias. Fetal tachycardia is defined as a fetal heart rate of more than 200. And as already assessed, we have to look at the rhythm by looking at the AV relationship. I use the M mode. You can also use a spectral Doppler. So we can have three types of atrioventricular relationships. The first is a situation where the atrioventricular relationship is 1-to-1, which means that for every atrial beat, there is a corresponding ventricular beat. Every atrial beat is conducted. Then you do another maneuver, which is the SVC iota Doppler, and then you can differentiate this into short VA tachycardias and long VA tachycardias. Mind you, SVC iota Doppler is useful mostly for tachycardias with a 1-to-1 atrioventricular relationship. Why is it important? Because the short VA tachycardias are pretty easy to treat, and often only one drug is required, while the long VA tachycardias, as which are shown here, are much more difficult to treat. AVRT is AV re-entry tachycardia, while AVNRT is atrioventricular AV nodal re-entry tachycardia. PAT is ectopic atrial tachycardia, while PJRT is paroxysmal junctional re-entry tachycardia. The names are not important for the non-cardiology people, but nevertheless, just differentiate between the short VA and the long VA. Then you have a situation where the atrioventricular relationship is more than 1-to-1. That means that there are more atrial beats than ventricular. So that is atrial flutter. And the third example is where the atrioventricular relationship is less than 1-to-1, which means there are more ventricular beats than the atrial beats. Typically, this occurs in ventricular tachycardia or junctional tachycardia. So if you remember this slide well, you will be able to answer some of the questions which are going to come up for you. So this is what I have shown. Again, repeating, for the fetal supraventricular tachycardia with 1-to-1 AV conduction, you should use the SVC iota Doppler. A longer, short VA means AVRT or AVNRT, while a long VA typically is a more severe type of tachycardia, which needs multiple drugs. So let us see the first tachycardia example. This was a 30-week pregnancy, primary gravida, who was referred because of fetal tachycardia with high drops. So this is a 4-chamber view. We can obviously see the tachycardia with a lot of high drops. So this is the heart rate. Whenever we say fetal heart rate, we are referring to ventricular rate. So the ventricular rate is 234. So obviously there is tachycardia. And now this is the M mode. We can see the atrial activity on the top and the ventricular activity behind. So now I will request the audience to type in the responses in the chat box. So what is this tachycardia? Is it a supraventricular tachycardia? Is it atrial flutter? Or is it a ventricular tachycardia? So people can type their response. There are no prizes to be won here, but it will be good to interact. And don't type in the Q&A, but rather in the chat box. You can put in the chat box. And I will move on.
Mainly atrial flutter is what you're getting, sir.
Yes, okay. So atrial flutter. So that's the right answer. Here you see the algorithm for evaluating this. There is a heart rate of more than 200, so there is evidence of tachycardia. Then when we look at the atrioventricular relationship, you see that there is atria is more than the ventricle. So clearly the answer is atrial flutter. Some of the atrial beats are conducted while certain others are not conducted. So there is more than 1-to-1 AV conduction. So the answer is atrial flutter. So this was a case of fetal atrial flutter with atrial rate of 514, the ventricular rate of 234, variable AV conduction, and there was evidence of compromised cardiac function with high drops fetalis. So the diagnosis is atrial flutter. Now let us see this case, which is also 30 weeks in a 4th gravida. This is a 4-chamber view, which shows clearly that there is a fetal tachycardia. And this is the abdominal section, which is showing a bit of ascites as well. So there is beginning of high drops. So this is pulse wave Doppler. And here the heart rate is 279. So obviously there is tachycardia. And this is the M mode, which is showing the atrioventricular relationship. So now people can again respond to this. So is it atrial flutter, or is it a supraventricular tachycardia, or is it a ventricular tachycardia? So these are our three important differential diagnoses. So what do people think here now? Atrial flutter, SVT, or VT? So a lot of people are replying it is SVT. So our next step in this case would be to go in for an SVC aorta Doppler. So that is what we have done here, an SVC aorta Doppler. And here the AV interval is 70, while the VA interval is 146. So then it will be an example of a long VA tachycardia. So that's the algorithm again. The heart rate is 279. So there is tachycardia. There is one-to-one atrioventricular relationship. So it could be some form of SVT. And then we looked at the SVC aorta Doppler. Then we have a long VA tachycardia. So the diagnosis has to be either an ectopic atrial tachycardia or paroxysmal junctional re-entry tachycardia. So actually you can arrive at a precise diagnosis by using these tools. So this case was an example of a long VA SVT with evidence of compromised cardiac function, and postnatal ECG showed that this was actually a PJRT. And this patient was successfully treated as well. Now we move on to the final tachycardia example. Again, you see the pulse wave Doppler. The heart rate is 237 here. So obviously there is abnormal rate. And this is the M mode evaluation. You can see the ventricle on top and the atria below. And this is how the rates look like. So you can see on top the rates. So what will be the diagnosis in this condition? People can type their response. Again, is it SVT? Is it atrial flutter? Or is it ventricular tachycardia or a junctional tachycardia? So again, a lot of people are responding that it is a ventricular tachycardia. So it's the algorithm is now pretty simple for everyone. Again, you have the heart rate of more than 200. So there is tachycardia. The atrioventricular relationship is less than 1-to-1. There are more ventricular beats than the atrial. So the answer has to be some kind of a junctional tachycardia, which is very rare. It is in this particular case, it was a ventricular tachycardia. So I hope the assessment of the rhythm as far as the tachycardia is concerned is easy and simple. You have to follow the stepwise approach. First, look at the heart rate, then look at the atrioventricular relationship. You can do it with M mode, and if you're really confident with spectral Doppler, you can do that as well. And by these two methods, you can actually say whether it is a atrial flutter, a supraventricular tachycardia, or a VT. And for the supraventricular tachycardia group, SVT, where the atrioventricular relationship is 1-to-1, you can do the additional maneuver to look at the VA and the AV intervals and classify the tachycardia into short VA and long VA. If you have done this, then you have done a complete and thorough job. So in this case, it is VT. Very quickly, the management principles. I won't take much time here. A lot of factors decide how we manage. The gestational age, for example, if somebody is close to term, you would deliver the baby and treat. Presence of hydrox will decide the choice of drug and route of administration and the type of arrhythmia. Usually now we generally take these pregnancies to 37 weeks plus, and we always prefer to deliver them in a pediatric cardiac center. Non-hydropic fetus can be offered monotherapy with digoxin, sometimes with drugs like flecainide or sotalol, while hydropic fetuses often need more than one drug as well. We always initiate the treatment inpatient. We admit the mother, do a baseline evaluation with all the blood tests and investigations. Specifically, the thyroid profile has to be checked. Always we load the drugs. We give high dose of the drugs initially, check the serum levels, and then continue maintenance and continuously monitor the fetus. So our treatment algorithm is we always admit the mother in the labor room and give IV digitalization in a dose of 1200 to 1500 microgram in the first 24 hours. After that, we continue the maintenance dose. Normally for the adult maintenance in a non-pregnant situation is 1 tablet daily, but in a pregnant lady, the volume of distribution is so high that if the baby has to receive these drugs, we have to give a pretty high dose. This is something which I learned by bitter experiences. And sometimes we combine it with combination therapy of flecainide, 100 milligram 3 times daily, or sotalol. Sotalol is a preferred drug for atrial flutter. I always begin the medications in high doses, and once we achieve control, then we reduce the dose. If the hydropic fetus doesn't respond to just transplacental therapy, we call the fetal medicine people for help and we administer digoxin intramuscularly to the fetal thigh. We do repeat the dose after 24 hours and then continue the same algorithm. Then once the control has been achieved, we taper the drugs based on response and monitoring, and we check the serum digoxin levels also, and then reduce the dose. So this is our atrial flutter case with high drops, and we gave intramuscular digoxin with sotalol, and within a week, the high drops vanished and sinus rhythm was established, and the baby continued to be in sinus rhythm. The delivery considerations, nowadays we tend to take these patients to near term, almost 37 weeks plus. And if the arrhythmia is not controlled, it's better to deliver in a pediatric cardiac center because the baby will need a postnatal management as well. And if the fetus is compromised with high drops, preferably a cesarean section may be appropriate. Now, many patients require postnatal therapy. Usually, beta blockers or digoxin is enough. Sometimes we give flecainide, amiodarone, etc. For flutter, direct cardioversion is a treatment of choice. Most cases, 6 months to 1 year will be enough. And atrial flutter in particular, we need short duration therapy only postnatally, and they have excellent long-term outcomes. Now, if you have a refractory tachycardia like the long BA tachycardia, these patients may require longer therapy, and sometimes they may require a specific electrophysiology study and radiofrequency ablation. And these are usually reserved for children who are a little older. So these are studies which have shown the role of various drugs. So my preference is usually flecainide with digoxin combination, while sotalol is the one which I typically use for atrial flutter. And we need to remember the fact that we have to treat these patients before frank high drops sets in. This is our data again published by Balaganesh as the first author. And in this we had 19 fetuses. 42% of them were hydropic. Of the patients who received, 18 received transplacental therapy and all of them survived. So overall, we can say that the outcomes of fetal tachycardia with an aggressive protocol-based management is very, very, very good. So it's now we have a standard protocol to manage these patients, and it's a pretty easy sort of a situation with a multidisciplinary team effort. Now we move on to fetal bradycardias, which by definition is a fetal heart rate of less than 100. Now there are two important causes here. The first is an actual atrioventricular block, and the second is what's called a non-conducted atrial premature beats. So first, let us see the algorithm. So the definition of fetal bradycardia is an FHR of less than 100. Again, we follow the same principles, the atrioventricular relationship. You see whether it is 1-to-1, then it is sinus bradycardia. If there are more atrial beats than the ventricular, then you can have either blocked APCs or second-degree heart block. And here you have to look at something at the AA interval, which I will come to in detail later. And finally, you have a situation where there is a complete atrioventricular dissociation, which is the third degree or complete AV block. So again, 1-to-1, 2:1, or varying AV relationship or complete atrioventricular dissociation. So this is another case sample of fetal bradycardia. You see that the rate is slow. It's 88 per minute. And you can look at the atrial and the ventricular beats. And now it's a simple analysis here. You see the heart rate is less than 100, so there is bradycardia. And we look at the atrioventricular relationship, it is 1-to-1. So it is an example of sinus bradycardia. Now, sinus bradycardia is usually due to a systemic cause, like various maternal conditions, placental insufficiency, etc. The one cardiac condition which can sometimes present with unexplained sinus bradycardia is long QT syndrome. Usually long QT syndrome typically presents with heart rate somewhere around 90 to 100 and doesn't change. So a persistent sinus bradycardia, if you exclude all the other conditions, maternal causes, placental causes, and if the heart rate remains at 90 to 100 or slow heart rate for the period of gestation, this is one condition which is worth remembering, and you should do a postnatal ECG for confirmation. Now, this is another very interesting case, and at 19 weeks, this fetus presented with this. So you can look at the overall 4-chamber view. You can see that the heart rate is slow. That does appear to be regular at times as well. And when we did the pulse wave Doppler, you could see that there is obviously there is something happening for the atrial and the ventricular. There seems to be more atrial than the ventricular. And then when we did the M mode, obviously you can see this. You can see the relationship. There is obviously more atrial beats than the ventricular beats. Now the question which I will ask to the audience now is this, what is the diagnosis? Is it a atrioventricular block, or is it a blocked atrial ectopic? So people can type their responses now. Is it a blocked ectopic, or is it an true atrioventricular block? So a lot of people have jumped into the answer. A lot of people have jumped into the answer. Everybody is responding AV block. So that's very good. So let us see how to evaluate this further. Let us do the analysis. I think it is very important to use your brain and not your heart. Don't be impulsive. Okay. So look at the M mode. We can see that there are more atrial beats than ventricular. So these are all the atrial beats which are conducted, while these are all the atrial beats which are blocked. So I do agree that technically there is a block, atrioventricular block. But before we decide that whether it's a true AV block or something else, let us look at the AA intervals. So these are one set of AA intervals, and these are the other set of AA intervals. So obviously the AA intervals are varying. Every second atrial beat seems to be blocked. So this was actually an example of premature atrial beats. Every second atrial beat was a premature beat. That is what we call atrial bigeminy. And the premature beats were getting blocked. So this is, again, slow heart rate, and then 2:1 relationship and varying AA intervals. So that was an example of a blocked APC. It is actually a catastrophe to diagnose this as a true AV block, because a true AV block is a much more sinister condition. Let us see what happened to this fetus. After 2 weeks, this is what I got. Completely normal rhythm with a fetal heart rate of 138, and there were no problems. So at 19 weeks, if you diagnose a 2:1 block, this baby fetus can lose its life. That's what you need to remember. So you have a lot of responsibility when you look at rhythm. And the key thing for us was the third step, where we looked at the AA intervals. Varying AA intervals means it is a atrial ectopics, while if it is a constant, then it is a true AV block. So illustrate, let us see this case, which obviously is a much more complex situation, bad obstetric history. First pregnancy, there was an abortion. Second pregnancy, there were other anomalies. The ANA profile and the anti-roller antibodies were negative. And this was the 4-chamber view. So obviously there is evidence of fetal bradycardia here. The spectral Doppler showed a heart rate of 68. And this is the M mode. Now you can see this M mode. And now you can give me your comments. What is the diagnosis? Is it blocked ectopics, or is it a true atrioventricular block in this case? So these are the two important differential diagnoses. So let us see what people are saying. Yes, so here now we have people true AV block. That's very good, because people have picked up the cue from the previous case. And here, let's see what is happening here. So this is the analysis of the M mode. So these are all the atrial beats which are conducted to the ventricles, and these are all the atrial beats which are blocked. So obviously, just like the previous case which I showed, there is an evidence of 2:1 atrioventricular block. But what's the difference here? Look at the AA intervals. They are constant. They are the same. So there is a 2:1 block, but the AA intervals are constant, which means that there is a true block. Every second atrial beat is blocked. So this is an example of a true atrioventricular block. The algorithm is, again, bradycardia is there. It's a 2:1 relationship, and there's a constant AA interval indicating a true atrioventricular block. A true atrioventricular block usually has an autoimmune etiology, or there is an underlying cardiac problem, while an ectopic is something which is a transient event which usually corrects by itself. So this is my final case, which is relatively easy, and again we can actually type in your answers. So this is again a primary mother referred because of fetal bradycardia. So this is the initial assessment at 23 weeks, showing slow fetal heart rate. Otherwise, the 4-chamber view looks unremarkable. There is no major pericardial effusion as well. I did a complete survey of the fetus from situs to the outflows. Everything was normal. The IVC was also intact. So this is the pulse wave Doppler. It is showing a heart rate of 50, and this is the MAV relationship. So you can look at the A's and the B's very carefully here, and I'll keep this slide for some time and look at the A's and the B's, and now tell me, what is this? Is it a sinus bradycardia? Is it blocked ectopics? Is it a true AV block? Or is it a complete AV dissociation with complete heart block? So you can put your answers. Is it complete AV block? So a lot of people are putting complete AV block in that. So let us evaluate the rhythm here. So the first step is the heart rate. So that is less than 100 for sure. Now let us look at the rhythm analysis. Now these are the atrial beats which are conducted to the ventricles. There are several which are getting missed. So look at the ones which are missed. Here 2 are missed, 2 are missed, again 2 missed, here 1 is missed, which means that there is absolutely no relationship between the atrial and the ventricular beats. The atria are beating in one way and the ventricles are having their own rhythm. When we look at the AV intervals, the AA intervals are constant. So VV intervals are also constant. So that is the key. You have varying complete AV dissociation and constant AA intervals. So that means that there is complete AV dissociation, that is complete AV block. So the diagnosis is complete atrioventricular block. Now, the fetal atrioventricular block, etiologically, 50% of them have maternal autoimmune disease. Typically, they're present between 16 to 28 weeks. The important antibodies are the anti-Rho, anti-La antibodies. But typically, they may be a part of the SLE syndrome in the mother, or they may just occur as isolated anti-Rho, anti-La positive state. The mother typically may be asymptomatic, but then it will affect the fetus. The first pregnancy may be spared, and more commonly, this anomalies happen with the second pregnancies onwards. Now, other 45% of the fetal AV block occur with associated heart defects. We saw example of left isomerism with heart block. The other condition is congenitally corrected TGA and sometimes with tumors. And typically, heart block which occur with heart defects has a much earlier presentation than this 18 weeks. The European multicentric study identified the following risk factors for a poor outcome. AV block. Gestational age at diagnosis less than 20 weeks, ventricular rate of less than 50, presence of high drops, and presence of impaired LV function. If there are no risk factors, 91% of these fetuses survive till term. And in presence of associated structural heart defects, that's the red line, the outcomes are much worse. So the protocol for treatment of fetal heart block includes a combination of steroids with beta agonists. And we don't use steroids for every patient. And this is our protocol. For low risk fetuses which have a pretty good heart rate with no high drops, no high risk features, we follow up or just give beta agonists like salbutamol. But for high risk features, we give a combination of steroid, which is usually dexamethasone, along with the beta agonists. So this was a postnatal ECG of the same baby, which showed complete AV block. And this baby actually was born prematurely because of fetal distress, weighed only 1.5 kilo, and we inserted an emergency temporary pacing, waited for the baby to become bigger and put a permanent pacing. And this baby is actually now 5 years old and doing well. And this is a paper which we published recently in the Journal of Fetal Medicine. And I think it's worth reading the importance of the analysis of arrhythmia mechanism in predicting outcomes in fetal bradycardia. And we identified 4 groups. The group 1 was blocked atrial ectopics, which all had excellent prognosis. Group 2 had second degree AV block, in which a number of cases had long QT syndrome. Group 3 had complete AV block, and the group 4 was sinus bradycardia. And sinus bradycardia always had an associated reason, associated problem like a placental or a systemic problem. So to summarize, evaluation of the fetal heart rate and rhythm are integral in fetal echocardiography. Most of the common rhythm anomalies are benign and self-limiting. Fetal tachycardias are an important treatable cause of non-immune high drops. Fetal bradycardia and AV block are more resource intensive and need long-term care and follow-up. So you need a multidisciplinary team approach in ensuring optimal outcomes in these fetuses. So these are some of the babies. This one on the top left is a baby with atrial flutter. She is now, I think, 5+. And this baby in the bottom, this one, which is the one which had that 1.5 kilo with complete heart block. So this is what I call the rhythm of life. So tremendously satisfying to manage these patients. And I never give up whenever there is a fetal, particularly fetal tachycardia. And a lot of people have learned this protocol from us and doing a good job. So thank you very much. And maybe we can just take a few questions, if any, from this presentation before we move on to the final one. Yes, Sanjeev.
So there's one question from Megha Nair. What is the significance of isolated intermittent fetal bradycardia, then normal rhythm at with 150 beats per minute in a 16 weeks gestational age fetus? No structural abnormality, mother on treatment for rheumatic heart disease, mother not on antiarrhythmic drugs. It's probably a case she has seen.
Okay, fine. I think most of these are ectopics, so that is what we discussed. And then the more common type of ectopics are the atrial ectopics. So I think if otherwise there is no hydrops, no other problems, I will just check the maternal thyroid status. Sometimes a hyperthyroidism in the mother may be one of the reasons why the heart gets irritated like this. So I will just do that, and I'll just follow her up after 2 weeks. In majority of the cases, these settle by themselves. Otherwise, you should have the guts to give a good prognosis and just follow up. And that's it. I wouldn't really panic at all with one single assessment.
Okay. Any more questions from the delegates in the audience, please? Dr. Bala Ganesh only is asking, sir, let us know the importance of assessment of mother's heart and rhythm before initiating anti-arrhythmic drugs.
Actually, I did not show one case in purpose because it was like a little bit complex sort of situation. It was actually a case where we had, a case which maybe I can show it in the very end if for the people who are interested, after the counseling session is over. This was a case where the maternal ECG was pretty important because it was a case of fetal tachycardia and the mother had long QT syndrome also. So, I think, and the second reason for doing the maternal ECG is that sometimes, the mother may have an underlying ECG anomaly or something which we want to make sure before we actually start some of the antiarrhythmic drugs. It is important to look at the maternal QT intervals before we start antiarrhythmic drugs because drugs like flecainide and sotalol can cause a significant prolongation of the maternal QT interval. In fact, the first case of SVT which I treated, the mother, I gave flecainide high dose, the mother almost had a VT before the delivery, and that was the reason why we had to deliver the baby. So that is why serial assessment of the QT interval is very important for these patients. So it's extremely important that, you need to sort of, look at the mother as well. In fact, the mother is bearing the brunt of this attack. The baby is safe and suffering, but the mother is suffering, not just the fact that there is a baby with a problem, but also she is in fact consuming these medications. So it is toxic to the mother. So it really, really needs a good teamwork here.
Okay, so thank you. Alpana, would you like to add something? Or
yeah, means actually, as we always say in our programs when we are teaching a fetal medicine unit, that this is one thing which we should always, send it to a pediatric cardiologist for the treatment options and for the overall assessment, because this is something which we can diagnose, but needs the treatment and a good counseling for this workup. So this is one case which I always, after detecting it, we'll talk to the concerned gynecologist and tell them specifically that send them to a pediatric cardiologist and don't send them, anywhere else. So as the obstetric unit, we should remember this fact very well. We should not really do any heroic things and try to assure the mother of anything. Always take a pediatric cardiologist opinion.
Okay, thank you. So there's one more question again from Bal Ganesh. Role of ivabradine in fetal automatic tachyarrhythmias.
What is ivabradine?
Yes. Basically, hemodynamically neutral profile drugs can
Ivabradine is it's a very new drug, and we are trying it in postnatal, life. I don't have experience of this drug in fetal arrhythmias. Perhaps, as Balaganesh has written, maybe we can think about it. I have not used it so far. Most of the algorithms revolve around flecainide, sotalol, and digoxin. Uh, Typically, all of us tend to follow things which within our comfort zone. These drugs have worked well for me. There is toxicity, so we continue to use it. But I think definitely we can consider this new drug in settings where the other ones are not proving to be effective.
Okay, so I think that's it from the questions. Let me just check the other box. I think there's one more question. Yes, sir.
Yes. This is something which is worth repeating. Sometimes I am getting a little bit bored because I have the same flow, but I think this is a lot of people have picked up useful points, especially the algorithms. I think it's very important, and this is something which we have learned from experience. I have actually put them for you. These simple things which everyone can follow. So I think I'm hoping that we'll break through these arrhythmias on a larger level.
There are a couple of interesting questions, so we could just take these. One is, can you confirm cutoff values for fetal bradycardia in the first, second, and third trimester? That's one question. The other is a reason of intermittent compensatory pause that comes in normal fetal heart rate while we are scanning.
Okay, the first question is bradycardia. Generally, most people agree with the persistently low fetal heart rate below 100. I think that's sort of a standard number. Cutoff. Standard. Some people use 110, but it is okay. 100, 110, it doesn't make much of a difference. The second is a compensatory pause. Compensatory pause is classically a feature of the ectopic beat. What the ectopic beat does is it resets the atrial pacemaker. So, before the next beat comes, there will be a longish pause. So when you look at the ectopic cycle, you have a normal beat, then there is an ectopic beat, and then before the next beat comes, normal beat comes, there is a longish pause. And then the next normal beat will come. And if there are no further, ectopics, then the normal heart rate will come. So compensatory pause is a classical feature of the ectopic. And what will also happen is the beat following the compensatory pause. And if you look at the velocity of the ventricular, wave, it will be bigger because there is more time for the heart to fill. So in the next beat, more blood will be ejected from the ventricle. So the V velocity will be more. So these are the two things which are very, very characteristic of the ectopic beats: the compensatory pause and the varying amplitude of the V wave.
All right, so I think that's it from the questions. We can just move on further to the next talk.
Final talk. Okay. So this is obviously a talk which is very close to my heart. Many a time this finds interest only in the cardiology forums, but I'm happy that we have still close to about 400 people listening, because this is actually much more important than everything else I have presented, which is prognosticating the fetal heart defects. So ours is a very large country, and obviously with the kind of prevalence CHD has, the number of cases which you will find in India will be very, very high. So we have about 25 million births in a year, and about 250,000 cases of CHD are picked up, and about 1 lakh needs surgery in the first year, and about 37,000 need surgery in the first 1 month. What we need to remember when we talk about counseling is that, many a time, these are the things you pick up. A small VSD, you get excited about diagnosing a bicuspid aortic valve, you get excited about echogenic focus or something, mild tear, but these are all essentially lesions which do not matter much. And even if you miss these, it's absolutely fine, because they have practically no impact on the life of the fetus or even the baby. Then you have these major lesions like TOF, TGA, DORV, etc. And these are all the lesions which will require surgery. And then you have the complex lesions, and where you know that even with the surgeries, the long-term outcomes are not good. So you need to understand that there are different types of heart defects when you talk about counseling. So that is why the diagnosis becomes very important. So the questions we need to ask is whether your diagnosis is accurate, and then what is the natural history of the lesion, what are the associated defects, the gestational age, the various treatment options, the long-term outcomes of the correction, and the long-term issues. So this set of questions cannot be answered by a single specialist. The cardiologist can give information about the diagnosis and the natural history, treatment options and outcomes, while the many things like including the diagnosis, associated defects, etc., often comes from the fetal medicine or radiology people. So we need everyone to be involved. I'm not an idealistic person, and I know that it is not possible to offer treatment for every single heart defect we diagnose in fetus in a country like India. So we will have to prioritize and make sure that those who have good outcomes, like for example transposition, they get a preferred referral pathway towards correction. While when you have very complex lesions, one may have to follow a more conservative approach. So this is where the entire options open up after prenatal diagnosis. You have so many things you can see now with these discussions we have been having over the last 2 days. We know that everything in the heart can be picked up, and you all can pick up the extracardiac factors. We can counsel, we can talk about the institutional experience costs, bring in extra age, and we have different options, starting from termination of pregnancy, which is based on our rules and regulations. I would not definitely want to go into the legalities of termination here because that's not a forum for this, but this is one option. Always go by the rules and regulations. We can go for a planned delivery and postnatal care. There are scenarios where you can offer in utero therapy. And then there is also this option, which is called comfort care. For example, a complex heart defect is diagnosed late in pregnancy. You give a diagnosis, you know that there is a reason why the baby is likely to do not so well. And if the family doesn't want to go for surgery, we can go for a very gentle newborn care and allow nature to run its course. At least the family will know that it is not an unexplained death, but it is due to a severe form of heart defect. Now, this is something which I really, really love, and I started talking about this a lot now. This is Kypros' slide, Kypros Nikolaidis, who introduced this inverted pyramid approach. I think the onus is on us now that we have the know-how, the knowledge, the technology, and the ability to do very early screening, and most of you do this very well as well. We should start this process from the first trimester itself. Do a comprehensive assessment for the NT, the genetic markers, look for the basic views of the heart, and that will pick up most of the complex multisystem anomalies. So there is no excuse not to pick up a multisystem anomaly early on. Then you can actually do a comprehensive diagnosis in the mid-trimester scan, and this is where the cardiologist often comes in. We can counsel and plan the decision. And the second half of the pregnancy should be primarily used for taking care of those patients who are committed to care for the baby after birth. For example, a TGA or a TOF without any other problem. So these are cases which should be followed up and handed over to specialized teams for planning the peripartum care. If we all work with this mindset, which is precisely what we have established in our center, we will have a great outcome. And this is very, very important. Detecting heart defects is never too early or too late. Most of the anomalies get picked up in mid-trimester, but the first trimester screening is very important to pick up complex anomalies and multi-system anomalies. And sometimes even in the third trimester, you can pick up lesions like a TAPVC, a coarctation, a tachycardias, or sometimes even a TGA. So whenever, and I will show you with an absolutely brilliant example how one of you from around Mumbai picked up something critical in the third trimester. So the first trimester evaluation as a part of NT focus on complex lesions like this one, which I showed as an example of left isomerism. And of course, the other is a complex CHD with multiple extracardiac anomalies. And this was actually a right isomerism with unbalanced AV canal with a sliding hiatus hernia, and even there was a neural tube defect. So these are all will add to the overall prognosis, and hence it's pretty much important to look for this. The next is the genetic associations. So this is AV septal defect, which has association with trisomy 21. This is a common arterial trunk, which has association with 22q deletion. So these are all the multi-system anomalies, and we should focus on these things in the first trimester. And this is an absolutely wonderful paper from the Czech Republic. And in this paper, they actually showed that the first trimester screening will modify the natural history of congenital heart defects so much that even the patterns of CHD, which you see during the second trimester, are different. Many of the hyperplasts, etc., are picked up early, and they don't even cross into the second trimester. The mid-trimester is where the standard protocols apply. And here, this is how I do it. We should always begin as a fetus with the hole. Then we should use a 4-chamber view to look at whether there are 4 chambers or not, the outflow tract number and obstruction, in utero progression, whether it is possible or not, and whether it is a critical postnatal presentation. So this is a sequence in which my mind works when you talk about the counseling. So the 4-chamber view, however much we talk about stick or anything, we cannot, stop talking about this, because this is where everything begins. This tells us whether the heart defect can be corrected or can only be palliated. So this is classical left heart hyperplasia, HLHS, which we saw yesterday. Then this is Epstein's with severe tricuspid valve regurgitation. This is an example of a hyperplastic right ventricle, hyperplastic right heart, PA IVS. Then we have this example of tricuspid atresia here. Then another kind of situation where this is what's called a double inlet left ventricle. So all of them have single ventricle, like hyperplastic left heart is pretty bad, and the DILB and tricuspid atresia are slightly better off. And then you have the abnormal crux AV septal defect, and now we have the unbalanced AV septal defect, which we saw in the last talk with right isomerism. So many of these lesions, especially the single ventricle types, need what we call multiple operations, what we call the Fontan pathway. And these have multiple stage procedures, risk, recurring costs, and there's a long-term issue of Fontan failure, many cardiac and non-cardiac complications, neurodevelopmental sequelae. And this is a data from Australia and New Zealand. They looked at the long-term outcomes of Fontan, and they found out that survival is okay, but a lot of patients require repeat procedures, medications, etc. Only about half of them are free from the medical events. And particularly for lesions like heterotaxy or hyperplastic left heart, the prognosis is very guarded in the long run. And this slide I showed yesterday, many lesions like HLHS and very complex lesions associated with genetic syndromes have neurodevelopmental problems. So this is our data, which is published in the Cardiology in the Young last year. And we had 500 plus cases with the univentricular heart. And more than 50% did not have live births. And of the ones who were live born, less than 50% went for the treatment. And only 21% were alive on the last follow-up. So you see that there is every reason to screen the fetal heart in very early on to pick up this complex anomaly. So I think it's the onus is on us to pick up these problems early in pregnancy. Now, regarding the outflow tracts, the first thing is to look whether there are 2 outflow tracts or not. So here is 2 cases where there are 2 outflow tracts, TGA and tetralogy of Fallon. And this is a classical TOF with an aortic override, which we see classical example of TOF. And this is a parallel outflow, so TGA. Instead of the crossing, you have parallel outflows. And this is a DORV case, which we saw. So all these are conotruncal anomalies where we have 2 outflow tracts. Now, this is another example of anomalies where you have only a single outflow tract. So this is an example of a TOF with a pulmonary atresia, and this is an example of a common arterial trunk. Now, how does it matter whether it is a single outflow or 2 outflows? Now, if you have only 1 outflow, like this is an example of a pulmonary atresia with VSD, in the repair, the surgeon will need to put an artificial graft called the RV to PA conduit. And this will need reoperations for conduit change as the child grows older. So that is what I told yesterday about the DORV. There are DORVs which can be offered a single stage correction versus lesions which need a conduit and thus reoperation. So this is very important. That's why the outflow number is very important. The 3-vessel view, as Mark and Dr. Alpana showed, is very important because it tells us a lot of information about the outflows. And one very simple clue to look at in the 3-vessel view is the PA to aorta ratio. And normally the PA is a little larger than the aorta always. And you can look at the abnormal vessel size. The first case is showing a small PA, suggesting pulmonary stenosis. Second one is a small aorta showing coarctation. And in the 3-vessel tracheal view, you can look at the direction of flow in the 2 arches. The first case is showing a reverse flow into the aorta, and here there's a reverse flow into the PA. And the presence of reverse flow into the one of the vessels is indicating a critical duct-dependent circulation after birth. Reverse flow into the aorta is called duct-dependent systemic circulation. They're present with cardiogenic shock after birth, after ductal closure, while the reverse flow into pulmonary artery is a cyanotic emergency. It's a duct-dependent pulmonary circulation. And all these babies need emergency institution of a medicine called prostaglandin after birth and a newborn procedure. Now, we discussed about TGA screening views, but I would say that the three vessel view is very, very important. Normally in the three vessel view, you see the three vessels as seen here. TGA, the classical picture is you see the SVC and the aorta. This is not specific for TGA, but it gives a valuable clue in screening. And in fact, there was a study which was done in Netherlands in which they, by using this particular view, they could pick up 84% cases of TGA. So I will, if I have to teach one fetal heart view, I will go on teaching the three vessel view everywhere just to pick up the TGAs. Now, third trimester evaluation is also important. So whenever you put an ultrasound probe on the fetus, look at the heart always. And this is useful for follow-up evaluations. And sometimes some lesions may progress in utero. And this is a case which somebody, actually, I have shown this many times, you know, a little ball-looking left atrium here, and nothing is there. This is not done by me, but it was actually picked up by an astute radiologist practicing near Mumbai. There's a common chamber behind the LA here, and you can see that in the three vessel view, there are four vessels, and then there is this dilated brachiocephalic vein. So this is a picture, you see a dilated brachiocephalic vein. This is a case of a supracardiac TAPVC, which was picked up in the third trimester, and the patient was simply referred for a growth scan. So it is very, very important to look for the subtle clues. The clues in this was a minimal ventricular disproportion, prominent RARV, and a little ball-looking LA. The radiologist couldn't pick up the pulmonary veins draining into the left atrium. I'm not saying the name of that radiologist because that person has told me not to say that name anymore. I have told this in some forums, but now I have been warned not to say. What that person did was, after diagnosing, contacted me, then contacted the cardiologist there and got the patient referred to a center where surgery was possible, and the surgery was done and the baby had a great outcome. So that is how we all should do. Another reason to look at the heart of the third trimester is this in utero progression. Here we have tetralogy at 24 weeks progressing to pulmonary atresia at 32 weeks. So that is how it is important. So this is not the picture you are going to see when the baby is born. And this is the picture. So that's extremely important to do the follow-up evaluations. So the first case, there is an antegrade flow, and by 32 weeks, there is a retrograde flow into the PA. And this is, of course, the arrhythmia case, which I showed. Many arrhythmias present in the third trimester. So this was a baby, which I showed again, the atrial flutter after treatment. Right. So the new paradigm, of course, is prenatal diagnosis and planned delivery. This is what Mark was saying. So normally for a baby to undergo care, somebody has to suspect heart disease after birth, do the echo, refer the baby, transport the baby to a cardiac center. Many a time they come in a bad preoperative condition, so we have to stabilize the baby and then we have to do surgery. So this is a risk zone. And most of the deaths happen during these 4 steps. If you have prenatal diagnosis, you can eliminate these steps. The danger zone is eliminated and the baby can be born in the cardiac center and go for surgery early. In our center, we are currently operating most patients at a mortality rate of less than 2%. And this is the data which Balaganesh did. Balaganesh has been a prolific paper writer with us, published many, many papers in fetal and other areas. He identified the transport as a weak link, and because a lot of damage happens during transport. And so the new concept is to prenatal diagnosis, direct delivery to a cardiac center, as Mark briefly said. And there's a lot of data from the Western countries showing the benefit of such a strategy. And this is particularly useful for lesions like TGA, duct-dependent circulatory states, TAPVC, CHTs with severe hemodynamic compromise, and uncontrolled fetal arrhythmias. So our own data, which shows that there is a significant increase in the number of planned deliveries and the newborns with prenatal diagnosis increasing. Even the termination rates have started to fall with proper counseling and availability of care through the government scheme. At 2013, the termination rate was 39%, and the last 2-3 years it fell down to just 20% after prenatal diagnosis in my data list. We have published the benefits of prenatal diagnosis in improving the preoperative status. We also have data suggesting that heart surgery can be performed earlier in prenatally diagnosed cases, and the overall mortality is reduced by 1/3 in the newborn heart surgery. Just 3% compared to 9% when the diagnosis is made after birth. And for TGA, this is pictures again taken by Ganesh in a prenatally diagnosed case. This was a picture when the baby was born. The oxygen saturations were 30%. Within 20 minutes, we did a balloon septostomy, following which the saturation increased to 80%. And this is one of the most important papers which we have published. This is by my fellow Farouk, who published this in Ultrasound and Obstetrics and Gynecology, showing the significant impact of planned delivery in TGA. Quite staggering. We haven't lost a TGA for a long, long time after prenatal diagnosis. So in TGA, prenatal diagnosis and planned delivery not only helps earlier surgery, but also improves the outcome substantially. And now we have data suggesting that the prenatal diagnosis and planned delivery reduces the cost of newborn heart cardiac care by as much as about 20%. So almost a difference of about 75,000 rupees to 1 lakh rupees difference is there. And this is very important. And this data also we have now submitted for a publication. So these are being shown to show that the prenatal diagnosis is life-saving in a large number of conditions. Right. So let us come to the end of everything. So even if you don't do stick, if you do the basic views right, the 4-chamber, the outflow tracks, and the 3-vessel view, you will pick up everything which is important. And then you apply the counseling algorithm like what is shown here. And the 4-chamber view should be used to pick up all the complex anomalies early on, while the outflow tract views should be used to pick up the critical anomalies. So this is one slide which I don't mind people taking a screenshot, because this is entirely for you. So I have put every CHD in the fetus into perspective. The first is benign lesions, where you don't need to do anything in most cases. Typically a left SVC, a small VSD, most cases a bicuspid aortic valve, mild P.
I'm in a webinar. I'm one of the panelists. Can I call you later? Huh? Okay. Yeah.
Dr. Mridula, can you please? You are audible, Dr. Mridula. The second group of conditions are where you can actually perform a single stage correction with a normal life expectancy. ASD we are not going to talk about, but BSD, coarctation, TAPVC, etc. Then we have lesions like TOF, TGA, most forms of DORV, newborn coarct, where anatomical repair is possible with 95% adult survival. Then you have more complex lesions like a TOF with pulmonary atresia, a common arterial trunk, complex DORVs. Here, anatomical repair may be possible in some situations like a TOF pulmonary atresia, common arterial trunk, but most of these patients will require reoperations. 85% adult survival. And finally, you have this very, very complex lesions like HLHS, complex heterotaxy, severe Epstein's, where you need very complex repairs or palliative repairs. Reoperations are universal with less than 70% adult survival. So if you start drawing the lines, between this is what you really get. So the projected scenario is if you screen the fetal heart in all pregnancies, pick up complex CHDs early, counsel them appropriate options, critical CHDs, plan peripartum care, and thus you can optimize the outcomes. So this should be the one who's thanking all of us. This is a baby who had prenatally diagnosed TGA, and look at the fist. He is making a fist like Messi today after he won Copa America. God knows whether this one can be another Messi. So I would rather have this baby say thank you to all of you for participating. And it was incredible experience for us as faculty members to go through this rather long sessions. But I believe overall everybody enjoyed these sessions. So I'll stop sharing and I will hand over to the panelists for any final comments and questions.
Thank you, sir. That was really wonderful walkthrough. Any delegates wish to ask anything from Dr. Balu? I mean, absolutely anything, as well as from Dr. Alpana. Okay, it could be pertaining to this or to any other sort of points you have or queries which you wish to solve, you can please go forward now.
As in the morning before we started, I was discussing it with Dr. Balu that this talk of his is actually the most important talk because, in fact, there should be always in the forum, especially of the fetal medicine units, it should be taught the basic knowledge of how the postnatal care is done, basic operative sort of basis for how the operative surgeries are done, because usually at 19 weeks when we tend to diagnose certain conditions and we just say that this is a major cardiac abnormality, it will need a lot of surgeries and a lot of expenditure, and then the parents without doing anything just opt for the termination, and that should be avoided. So that last slide which he showed is actually very important. The things which have a fair prognosis, better prognosis, this should be told to the patients, and there are options for non-expensive surgeries possible, as he always says, and they can be at least given the chance of meeting these the cardiologist and then taking the opinion. So this was a very important discussion. In the chat box, if we have any questions, Sanjeev.
Yeah, I'm just looking. Nothing so far. Let us, we'll just wait a little. Dr. Mrudula also will be announcing the winner shortly of the papers and poster presentations. But I think Dr. Balu has one more to go, right, sir? Yeah.
I'm done.
Yeah, we are done. So anything else anybody wishes to ask? Otherwise, we just go forward for the announcement of the papers and posters. I think, Mrudula, you can take that forward. Yeah, and
sure.
then we can come back if there are any more questions coming.
Yeah, that's better.
So I'm just sharing my screen for the poster results first. There were excellent entries for both posters and papers. Really lots of efforts put up. But let me announce the 3 best posters. Now, the prizes have been majorly given based on the images, the image resolution, and the explanation over the images, as images in radiology, fetal medicine, and fetal echocardiography stand of a great importance. So I'm really glad to announce the poster results. The 3rd prize goes to Dr. Sujoy Mani, a PG resident from MGM Mumbai. Many congratulations. The topic of presentation was hypoplastic left heart syndrome. The 2nd prize goes to Dr. Seema from Janani Scan Center, Gulbarga. The poster was really very impressive on right atrial isomerism. And the 1st prize goes to Dr. G. Venkataraman, Hyderabad, on Untangle the Entangled Complex Cardiac Conotruncal Abnormalities. So this is about the posters. Now, I'm sure everybody is eager to know the paper results. Again, very good papers, great efforts put by the postgraduate residents. I was very impressive entries. So let me announce the prizes. The 3rd prize goes to Dr. Vidya Rameshti, postgraduate resident from MMISR Medical College, for her excellent paper on 1st trimester cardiac evaluation. 2nd prize is shared over here between Dr. Seema Yadagiri, again Janani Scan Center, Gulbarga, for her paper on conotruncal abnormalities, and Dr. Sujata Alauni, Amrita Institute of Medical Sciences, Kochi, segmental approach to cardiac diagnosis of prenatal case scenario. The 1st prize goes to Dr. Satish Mohanty, again Amrita Institute of Medical Sciences, Kochi, prenatal diagnosis of redundant foramen ovale flap mimicking an aortic coarctation. Many congratulations to the winners. I'm stopping my screen share, and this will be put up shortly and mailed.
Oh, that actually makes me very happy, Sanjeev, because I think always teaching has to begin from home, isn't it? So some of my people have actually taken up this very seriously, and as a teacher, it makes these efforts feel very good. I want to actually congratulate all these people who have participated. This was one of the best events I have done in my especially the virtual event. It is amazing. I should say that I'm a bit tired now, but didn't sleep well, because I was just the adrenaline surge was so high. So, and of course, morning.
We could see that on screen, sir.
Yes, other things, finally Messi won a championship during his career,
Okay.
and I really wanted him to win. today. So absolutely worth this,
Yes, sir.
Uh, so it was like an unbelievable session, and very, very happy,
I'll
So,
just announce the fetal eco quiz winners also. So
yes.
I'll go with the answer as well as with the winner. We had quiz one, Krista Terminalis, Dr. Pradosh Sarangi. Biventricular cardiomyopathy was answered, but a little later, Dr. Mark gave away the answer. Three was ductal constriction, Dr. Raj Bezdadia. Four was tricuspid valve dysplasia, Sujata Alwani. Five is Epstein's, Amok Jagtap. Six is absent left lung, Ashok Bharti. Seven, all three VSD was answered by Supratik Basu. Eight, which was the combination of asplenia, single ventricle, etc., was answered by Swapna Ramgopal. De Georges syndrome was answered by Basil Matthew and Raj Bezdadia. 10th was the left ventricular aneurysm answered by Advait Takle. 11 was AP window by Dr. Pankaj Rote. And TOF was answered by Meghna Katkar first. Many got it right, but these were the ones who were fastest on the keyboard. So they win the prize. We'll be giving you gift vouchers. They will be received by all in your email shortly. And we finally come to an end, but Dr. Mitusha is here, and we're actually continuing the program into a MRI Prelude series. But before that, I think Mitusha will take the mic and call on Dr. Patkar also to say a few words. Mitusha, please. Yeah.
Thank you, sir. Thank you for giving us an opportunity to be a part of this absolutely wonderful event. And these three great speakers taking all these important topics, it was really a learning fiesta and experience. Before we go ahead, as we decided that we will continue this as a prelude session for the upcoming 20th MRI teaching course, which will be in August, I would request Dr. Deepak Patkar, sir, who has been a constant force for all these Indian Radiologist event masterclasses. We did breast masterclass, cardiac masterclass, and now fetal echo masterclass. Sir, kindly share your thought processes and please spare a few minutes for our delegates before we go ahead for the prelude.
Thank you, Mitusha. Thank you, Sanjeev. Thank you all delegates for such an overwhelming response to this masterclass. I thank our respected speakers, Dr. Mark, Dr. Alpana, Dr. Balu, for addressing this very important topic of fetal cardiac imaging. We radiologists truly are resolutely trying to expand our turf, and it's not easy. Due to the current pandemic, we are conducting all these masterclasses on digital platform, and it has been an overwhelming success. So on site platforms, we were happy to have 100, 150 people. We now easily cross 400, 500. So that's the brighter side. The other brighter side is you can attend these classes from the comfort of your home or clinic. We promise to provide you with a virtual learning experience of the highest caliber. Congratulations to the other team members from Indian Radiologist, Dr. Jignesh and Dr. Shailendra, for having us do these spectacular events. In the past 2 days, we've covered a lot of topics on this Fetal Radiology Masterclass series. I am also grateful to all our front-end and back-end volunteers, Mitusha as always, Gauri, Mamta, my wife, Dr. Amit, and of course Priyanka, for all the effort that they take behind the scene. As one program draws to an end, we are ready with the next series of courses for you. The 20th MRI Teaching Course starts on 7th August. Dates and details of the course have been shared on the various social media platforms, and I'm sure many of you are aware of it. As before every movie release, there is a trailer, and the MRI Teaching Course starts with its preludes. Today we launch our course with 2 lectures by eminent speakers, Dr. Manjari Dighe from Seattle and Dr. Alok Jaju from Washington. Every Sunday, we shall get you a sneak peek into the mega event planned over next 4 or 5 weeks. So please stay tuned and register for the main course. Thank you all.
Thank you, sir, for those inspirational words. And as you correctly said, every time one event comes to an end, the other one is ready for our delegates. So with this fetal echo coming to an end, but definitely it has acquired interest in all our viewers and delegates in this particular topic of fetal echo. And not only this, already the chat box is filling up with positive comments. People are saying it was totally an eye opener, the entire session. So thank you once again to all the speaker panelists. Thank you, Mridula ma'am, for all your support. So now I would request Amit sir to please play a short video and for the prelude session, and then we can move ahead to the prelude session. Yes, sir. Yeah,
Yes.
Dr. Patkar.
Maybe I would like to sort of say my gratitude and sincere thanks to everybody in the Indian Radiologist team. It is a great pleasure to work with you again, and we hope to have this continued activities. And finally, Dr. Alpana, it was a great honor to be with you for the last 2 days. Amazing discussions with you. Great honor for me, and I really look forward to more sessions with you in future. And to everybody, all the delegates who attended the session, and we had really good audience throughout. Thank you so much from the bottom of our hearts. Maybe with your permission, I will take leave and maybe get some rest and lunch. All the very best to all of you, and let us pray together that the pandemic ends very soon. Thank you very much.
Thank you, sir.
And
Thank you.
Yes, Dr. Balu, same feelings here. It was nice working with you. I have a tremendous respect for you because of your that pediatric cardiologist perspective in fetal echo. Fetal echo is my passion too, and it was nice working here. And of course, Sanjeev is a friend. I always say I will stand by him, but I am getting to know a lot of more team members of Indian Radiologists. So thank you all. Thank you, Mitusha. Thank you, Mridula. Thank you, Sanjeev. And
Thanks, Kalpana. Thank you for being here.
bye, guys. Thank you.
Thank you. Thank you.
Thanks, Kalpana.
So with this, now it's time to move ahead with the prelude session for our 20th MRI teaching course, one of the much awaited annual conferences. So this is the 20th year of our annual MRI teaching course. We have been running this course on site with almost more than 400 delegates. But last year with this ongoing pandemic, we shifted to the online pattern. It was very new for us as well, but the response was overwhelming with a lot of advantages of this online setup. As all of us know that it gives us an ease to attend these programs at our comfort levels. We can skip traveling to places and staying for long times, and even the experts, we could receive their speakers, we could receive from international as well as the national forum very, very conveniently. So with this, we have decided yet another event, the Monsoon Edition 20th MRI teaching course, to be an online event. We started thinking that we'll have an hybrid event that will be on site and online. But due to this unfortunate continuing pandemic situation, we have decided to keep it online. But the good news is the course has been extended from the routine 3-day pattern to the 5-day comprehensive course pattern, where we are going to cover a dedicated day for the physics topics, because earlier we used to have only 2 or 3 basic lectures for physics during the 3-day course. But as the beginners, the residents who attend the course, they requested that physics and anatomy need little bit more details for them. So we have kept 1 full day for physics topics, which will be 7th of August. And it will cover all the relevant aspects of MRI basics and advances in physics. Then we will have a second day, which will be 8th of August, Sunday, covering all MRI anatomy topics, which are going to be very relevant for all our residents who are going to start their MRI readings. And again, we will cover neuro, MSK, relevant anatomical topics. These will be short, dedicated lectures, which will cover topics like anatomy of CSF spaces, cranial nerves anatomy, so that the topics are like covered in 10-15 minutes each, making it interesting and easy to remember. Similarly, we will cover anatomy of knee, shoulder, ankle, elbow, wrist, all these joint spaces, whichever is important and relevant. With these 2 basic days, 7th and 8th of August, we will move to the next part of the conference, which will cover the MRI in pathologies. So the first day will be neuro, all relevant neuro related topics in MRI as well as basics and advances. And we'll have all our speakers from international and national forums. Next, we'll have on 14th of August, covering the entire range of topics in MSK imaging related to MRI, and it will definitely cover everything, including basics, advances, everything which is new, like cartilage mapping, DTI in peripheral nerves, peripheral neurography, plexus imaging, and everything which is relevant for all our practicing consultants and upcoming radiologists. Next, the last day, we'll cover the relevant topics of body imaging, which will be pertaining to cardiac, which will be pertaining to breast imaging topics, topics like multiparametric prostate imaging, and also female, male, like related malignancies and HNF topics. So I request all of you to please stay tuned, register for the course. It will be a comprehensive update for all of us who are practicing MRI and all of us who are thinking to start practicing our MRIs. So we have already a great panel of international speakers for the course. Dr. Jayant Narang, Dr. Ashish Chawla, Dr. Vinil Shah, Dr. Ankit Tandon, Patkar sir will be there with us. Dr. Manjari Dige, Dr. Gaurang Shah, Dr. Asim Lahiri, Dr. Jim Wu, Dr. Kedar Jambekar, Dr. Rajan Jain, Dr. Raj Kedar, and many more. Not only this, we will definitely require your support, and we urge you to please submit your papers and posters. The last date is 1st of August, and all of you are welcome to please submit your papers and posters. The guidelines will be shared on all the social media platforms and also will be available on Indian Radiologist website. And it's very simple, just a PPT format of 20 slides, and you have to just submit it on this mail ID given. We are thankful to the organizing committee members, Dr. Sanjeev Mani sir, Dr. Deepak Patkar, Dr. Jignesh Thakkar, Dr. Shailendra Singh, and myself being a part of the organizing committee, and our support, Dr. Gauri Ahuja and Mamta ma'am. Also, Dr. Amit Punkar, who has been a strong technical support for all these events by Indian Radiologist. So